All right. Well, thank you very, very much. It's how exciting to have so much energy in the room. Can you guys hear okay? The mic is in the computer apparently, and I'm used to holding something. So hopefully you'll hear me, and I'll pretend that I'm yelling at the kids. So thank you very much for being here. Your participation today is really what makes this such an incredible event, and I think it will be a very important reason for a very important meeting for reasons that will soon be made clear. So I particularly want to thank our panel. I will introduce, and our speakers, I will introduce them soon. It was not by intent that all 8 panelists and speakers are women, but I just reached out to the people that I knew could speak to this question, and that's the way it ended up. So I think that this is an important meeting for this reason. 5 years ago, if you had asked me what was the most serious issue that employers face in healthcare, I would have told you or referred you to the Institute of Medicine's 1999 report that said it's utilization, a combination of underuse, overuse, and misuse. Since that time, the market has changed. And actually, any number of economists have recently suggested that the number one issue now, by the way, the use issue didn't go away, the number one issue now is price. Even in those markets where utilization has gone down, total costs continue to rise because of pricing. So that's the question that we want to engage, and particularly this question: if the market changes, shouldn't our purchasing practices change along with it? So we're going to look at a couple of these questions today, and we're going to do that with a couple of presentations, and I'll come back to that in a second. But particularly we're going to focus on this question: is there a better way to negotiate contracts rather than down from some unlimited charge master to up from some fixed empiric base? And to do that in a way, particularly that advantages, on the one hand, our families, our employers, our economies, but is also reasonable with regard to the providers of healthcare that take care of us. So the theme of the discussion today will be let's fix problems, not fix blame. One of the problems, and one of 3 problems I would suggest that we'll look at with regard to pricing, is the variability. This is an actual, I think it was 2017, it could be 2016 data, pricing variations in the marketplace for Denver. And what you see are market variations on average of about 800%. We've been looking at this for a couple of years. And here's the interesting point about this chart. This is not across networks. This variation takes place within networks. Okay? And people have no idea. So the market functions like this. You pull into a gas station that doesn't post its prices. You fill up. Partly on your credit card, partly on your employer's. You have no idea what you paid, and a month later, you find out, or 60 days later, you find out that you either paid $2.20 or $18 for that gallon of gas. And that's the way the market works. Now, if we want to fix problems and not fix blame, where's the issue? Well, let's follow the money. And what this slide suggests is that within the same network, while we do see some variability in pricing with regard to the physician contracts, which is in blue, the vast majority of variation is clearly on the facility side. So that raises the question then, how do we know what's fair? How do we know what would be a reasonable price? And for the last 20 or 30 or 40 years, we've said, well, we'll buy it on a percentage discount, okay? And really that gives a discount from what, okay? My 60% might be worse than a discount than your 30%. So that's the issue that we need to get at, and it's from this premise. We really, it's not helpful to say we have a broken healthcare system. Providers are really smart. they can provide very good care, and they could do it very efficiently if we create the right marketplace. This is about a dysfunctional market, and I say dysfunctional because it is not bringing reciprocal value proportionate to both the buyer and the seller. And that's the premise of what I would suggest. And that's not to blame anybody. That's to say that's the way the market works, because three factors cripple any attempt to be a proactive purchaser. Three factors. One, the current basis of pricing, which I touched on. Secondly, the opacity of the pricing. You have no idea for both quality and cost, and the unbundling. A hospital will have anywhere from 15 to 20,000 items on its charge master. So while pricing transparency is a good idea in concept, in reality, you'd have to have it in 8-point font and it wouldn't fill this wall. Okay, so no one could make sense of it. So that's what we're going to talk about. And now, if you think, by the way, if hospital pricing is intimidating to you, consider this quote from a renowned healthcare economist. He said, "I'd rather explain the virgin birth than try to justify pricing in healthcare." And it's a great article if you haven't read it. So what we're going to do is try to take that on. And this is not for the faint of heart. But I want to recognize two parties. One, Civic. This would not be possible were it not for the fact that Colorado has an all-payer claims database. Okay, that puts us just absolutely light years ahead of other states that don't do this. The second, so I want to thank Civic for all their work in putting up with me, and I actually have to thank a lot of people for that. But Civic's really been terrific, and they are an amazing. So we partnered with Civic because they are an unbiased, unprejudiced group. They are there to be a neutral party and simply allow purchasers and policymakers to make decisions based on empiric evidence. So that's what they're there for. That's how we use them. So you'll see some fascinating stuff, and you are going to hear two amazing examples of what leaders in the country are doing with this information. Marilyn Bartlett will talk with you about what the state of Montana, and I really, really admire this lady and what she's done. And then Gloria Sakdev from Indiana was actually the first state in the country to do the kind of analysis that you will see this morning, and she's leading an effort to do this on a nationwide basis so we can begin to have some comparability across markets, because this is at the end of the day about how healthcare is bought and sold. So, and then we're going to have a great panel. So without further ado, again, I didn't plan that all 7 of these folks were women. It just worked out that way. I'm particularly honored and appreciative of the fact that both our Lieutenant Governor and the Executive Director of HCPF came, as well as Representative Janal. Thank you very, very much for being here. I want to thank Anna English for her work, Janet, and then I mentioned Gloria. So without further ado, let me turn this over to Lieutenant Governor Donna Lynn, who has a few opening comments, and then we'll hear from Kim Biff-Stepher. So I know the Lieutenant Governor was here. Oh, there you are. Thank you.
Well, good afternoon. And the answer to your question is, why are there all women? This is what I often say about myself. We are GSD girls. Does anybody know what that means? Oh, someone said get shit done. I didn't say that. I usually edit it. I say get stuff done. But no, thank you. I'm going to take you everywhere. But it's an honor, actually, to be here because I feel so connected not only to the business group, because I used to run a business group in New York, very similar to what the Colorado Business Group on Health does, but just because I've sat in the shoes that many of you sit in and understand that we need leadership to tackle this problem, and we need a really collaborative effort. So Bob, thank you for bringing everybody together today, and for the Chamber for hosting us. And it's my honor, yes, to have Kim Biff-Stepher, who joined the state to be leading HCPUP. And as you know, HCPUP in the Medicaid program is a huge purchaser of healthcare. And I think thematically, what I'm going to talk about and what is obvious, and I think you'll hear from the state of Montana, is the power that government has to actually influence some of the things that can happen in the marketplace. And Representative Janal, who is the chair of the Health Committee and a great partner for me and for many people in the state. So I've had the privilege of having a lot of healthcare system. I've been a purchaser, a large employer. Actually, for the city of New York, there were 1 million covered lives. I've been on the hospital side. I worked for a public safety net hospital and also for Kaiser Permanente, which is both a payer as well as a provider. So, and unfortunately also the fourth leg of the stool, which is, or the fourth P, which is a patient. And as Bob was describing, not just variation, but the mystery of what happens in healthcare, I do think, I think I can share this personal anecdote. I get a little worried sometimes, but so I had a kidney stone about a year ago. I didn't have a choice of where I went. It was emergent. And I was in the hospital, not overnight, but literally for 6 hours. And you're correct. 3 months later, I got a bill. I got a bill for $48,000 for 6 hours in the hospital. And my first reaction was just to be feisty and call the hospital, which I did. But most people wouldn't, because by the time the insurance company pays it, what I was left with was a $500 bill, which, I didn't necessarily feel like arguing about. I thought that was okay. And I had no transparency into what my health plan paid. It could have been that they negotiated the charges down. It could be that they just had a reference price. But that's sort of the state of healthcare that I think we're in. And none of that is new to this group, but I want to share with you a couple of things that both, the state is doing and hopefully the state will continue to do. Because as I said, we're not only a purchaser of Medicaid, and you'll hear from Kim, $10 billion of our $30 billion budget goes into Medicaid. And we deserve, and you deserve, because at the end of the day, you're paying the taxes that allow us to pay Medicaid. You deserve to know what the state is doing to make sure that money is being spent wisely. We get value out of it, and we're doing a really good job in working with all of the different components of the healthcare system. We're also a purchaser of healthcare for our state employees. And one of the things that I tried to do a little over 2 years ago was to allow the state to broaden itself as a purchasing pool. And that happens in a lot of states around the country. You may know this. I worked in the state of Georgia. So think about, Georgia's not, it's twice the size of Colorado, but the purchasing pool that's under the state's umbrella is 700,000 people, because they invite municipalities, school districts, and other levels of government into their purchasing pool. Here in Colorado, it's only 31,000, but I can tell you, I'm gonna look at my they're still my friends, but my Kaiser people. If I was the state and I picked up the phone and said, you're about to lose your contract, they would stand on their hands to figure out how to be creative to hold on to that contract. So that was my theory, which was, if you allow local governments to buy into the state health plan, you get a better deal. You also can provide more information to the patients, the members. Unfortunately, in spite of the fact that we had bipartisan support, we had we had obviously Democrats who supported the bill, but we also had a couple of very brave Republicans who jumped onto the bill. But I've learned a lot about the legislative process in the 2+ years that I've been in my job. We couldn't get it out of committee. It got sent to die, along with some transparency bills. And you'll hear from Representative Janal. She wanted to provide some transparency in the pharmaceutical world. We also wanted to provide some transparency around hospital expenditures. Those things both got defeated. And this year, I guess the good news is we got a transparency bill through on freestanding emergency rooms, but it is, just a tiny piece of what I think that we ought to do as a state to facilitate you having information about prices. So it's obvious transparency is important. I often say, and some of you know this, we spend more time as Americans researching the cost and the quality of our washing machines than we do of our medical care. And partly because the information isn't available, but partly because our mind is in a place where, well, how do I find, right? I say to RJ, do you know a good neurologist? Meanwhile, I'm putting my health into the hands of a referral from a colleague or a friend. So whether it's transparency in prices or it's transparency in rates, it's really important that not just the business community and government come together, quite frankly, but those of you who are in the business come together, because I always say it's better to be part of the conversation than to be regulated. And you potentially are facing an environment where regulation will not be as flexible as if you sit at the table and we come to a solution together. So I know we've been on this journey for a long time, but I just want to commend the business group for its work and encourage all of you, whatever hat you're wearing here at the table, to learn from some of the organizations you're going to hear from and think about how, as we finish out this year and go into 2019, that we can continue some of this work to reduce our, it's not even, I can never even say reduce costs, because we're never going to reduce costs. We're just going to hopefully slow the growth curve, but we really have to do it not just here in Colorado, but nationally. So thank you very much and enjoy your panel.
Donna, thank you very much. I really appreciate it. I also want to, I'll introduce Kim in just a minute, but, and you do have, by the way, in the handouts, you have bios for our speakers today. The slides from today will all be available to you on our website, as well as a recording of the program today. It is being recorded, so we'll try to delete the 4-letter word. And no, that's fine. And and you know what? If you're not swearing when you're talking about this, you're not paying attention. Yeah, no, that's right. So, and I want to thank John Bartholomew for his support, both moral and financial, in running these data. So with that, let me introduce Kim. And Kim, I will pull up your slides. I have them open here, I think. And we'll turn it over to you. And if you would just introduce you. Yeah. There you go. And I'll pull up your slides.
Microphone here? So
This
this is a microphone, right?
no, that's
No.
well,
It needs to be green. And then
there you go.
All right.
Oh, that works. There you go.
So, quick introduction. So, Kim Steffer, 31 years, private sector, 31 minutes, government. Done the best I can. I had a very good mentor, Don Lynch, who's amazing, was my competitor at Kaiser when I was at Cigna. And always just beat the bejeebies out of it. Beat the bejeebies. So, we learned a lot from Kaiser, from quality, cost control. Really has done a wonderful job. So thank you, Donna, for your mentorship and your leadership and your contributions to the state and everything you're going to do for us going forward. Thank you, my sister. Awesome. How about that? So this chart is one, applause that you're all in here collaborating. It is just amazing. I've had the privilege of working in all 50 states, building multi-billion-dollar enterprises, and this state is very unique. The collaboration is amazing. So if we all got behind the objective on this slide, and this is compliments of the building in which we stand, the Denver Chamber. This is our economy, Greater Denver up into Boulder, and that sphere, fourth from the right, is healthcare. So it, like most other communities across the country, is the #1 driver of the economy. It's about 18%. We're going to sort of goal together in collaboration, grow the size of the sphere, because we become and are and continue to be an innovator in healthcare. The wonderful things come out of Fort Collins and Denver Tech area and Boulder and this great city and all across the rural communities. How do we export amazing things at University and Children's Hospital, and the inventions and innovations from Mary Ann's organization and Prime Health and all the wonderful partners, Catalyst that's building an industry integrator. How do we export? Because we are the place where the country looks for innovation. How cool is that? Okay, so get behind, we increase the size of the sphere of healthcare because we export, and get behind the notion that we decrease the size of the sphere as healthcare is paid for by consumers and employers. You all get behind that? You get an amen? I'll get an amen. Okay. So big deal. So thank you and applause to your collaboration to drive down costs for employers and for consumers. Thank you for that. So as we think about driving costs, you all probably have this chart for yourselves. This is Medicaid. So if we spend 10 billion, you can see the big circle in the middle, right? To my hospital friends, I said, there's bullseye on you. I'm not blaming, not throwing stones, my friend Catherine or anybody, but it's with this little something that big in the middle. If you're not paying attention to it, then you are not paying attention. Okay, so where you're focused, thank you for that. It's really important slice of the pie for our big pie chart for us we look at. So in our community, that 40, 30, 10. 40 is very typical for an employer's costs when they make their own chart like this. 40% typically of an employer's costs in the hospital. It's 30% for the state of Medicaid, and it's 10% of the overall state's budget. So it's a big deal. Thank you for your focus on it. Now, as you do your good work and focusing on hospitals, let's walk a little bit in their shoes because their world keeps changing too. This is the movement on the revenue streams as the hospitals feel them across this wonderful state. So if you look in 2009, 57% was coming from commercial carriers. And you can see that moving down to 49% over a period of time that we have here through 2017. This is complement of CHI, the Colorado Health Institute, and so appreciate that. And if you look now over to Medicaid and Medicare, which are those two light blues, you move from say 18% to coming on 25. Is that right? 35. So you have this 92% increase of publicly paid. Now, part of that's offset by this wonderful news of the uninsurance coming down from 13.5 down to 6.5, but it's not making up for the full movement of the higher prices paid for by commercial and the lower prices paid for public. So something we need to think about when you're walking in the shoes. And as you get in the weeds, why is that happening? Why is Medicaid moving up so much? Well, part of that's expansion, of course. It's wonderful news. But why isn't it more even? So we need to think about that as you're poking and prodding your hospitals. And this isn't equal all across the state. If you go into the rural communities, it's far higher on the public payers. The uninsureds are higher. So when you poke and prod at your solutions, one size doesn't fit all. You go into rurals, it's more difficult. And as we look at Medicaid, we have to pay more attention to what we're paying because we can be blamed for the cost shift to you. Okay, so here's some of the truth in the hospital provider fee. We're going to talk about that in just a minute. But if we bring in a lot of money from the hospital provider fee to offset some of the underpayments in Medicaid, we need to make sure that the employers get the benefit of that in lower cost shift. We're not seeing that. So that's a challenge as we think about hospital pricing, what money is coming into the state, how do we hold players accountable, and how do we also recognize the pain that they're in, hospital by hospital, system by system. As you look at hospitals, hospitals are the major player in many of the communities. They're a huge employer. When you look at what are they driving and what do we as a community want from them to make sure they're meeting the needs of the community, really, really critical. So let's take one that we all have heard a ton about, addiction, mental health. If we look at a hospital community by community, are they meeting the needs of the community based on what the community would voice if they were asked in detail? And how do we define this more appropriately? Because it's the key, not just about the billing, what we pay, but what services they're providing. So if we could think about that together as well, that's a big deal. Obviously, some of the lifestyle, we're going to push on costs. We have to, one of my business roles, my leadership roles, blame myself first. We all look at ourselves, blame ourselves first as a community. Where are we causing some of the price impact, the cost impact because of the lifestyle that we want to live? Socioeconomic and shifting demographics. So how do the hospitals rising through community health needs assessments? How are they rising through their 990 process? For the hospitals that are not for profit and they're not paying taxes, how do we define as a community what we need from those not-for-profits? Because remember, we went back to this graphic. It is the #1 economic stimulus. The bulk of those hospitals are not for profit, not paying taxes. Holy cow, it's $50 billion in spend across revenue coming in. Not much of that is not, most of that is not paying taxes. We need to figure that out, defining what is needed in the community. Big revenue miss. There's an opportunity there for accountability. So we talked about the community, demographics within the community. This is a big deal. These are seniors, right? They're growing like a weed. Some of you have heard me say this before, but that senior population grew by 43% in the last 7 years. Will grow by another 53% in the next 12. So when we think about hospitals, how do we meet the needs of the communities as it's referenced by seniors? Some of that is, how do we scope creep a little bit? What do we need? How do we complement the hospitals? How do we have referrals from hospitals that go to efficient delivery to seniors? For Medicaid, they're 3% of our population, but they use 17% of the resources. Double that, and you can define problem very quickly, right? We're already 34% of the state's budget, and we're taking care of, remember, we took away from seniors, we took away pensions. If I'm 84, could I have figured out that it costs this much over this period of time? Holy cow, right? So how do we, working in the community, what's a hospital's obligation? It's the wrong word, too strong a word. What do we need from, what does care look like? And if it always goes to the hospital, and that's inappropriate and the most expensive, and it's inappropriate, wow, okay, we have a building problem if we don't figure this out. It's not getting smaller and it's not going well. And this is mom and dad. What's more important than taking care of mom and dad? When you think about hospitals, I want us to think of, are we maximizing innovations? Are we falling to our knees because of some of the innovations and the cost impact, like specialty pharma, right? Specialty pharma, yesterday I treat cancer and leukemia, and I do it exceptionally well for a small price, and now I have $420,000 drugs. When do I use those? When is it beautiful? And when is it horrifying? Okay, how do we hold our hospitals accountable? Because it's very profitable as well. As hospitals buy up physician groups, this is very profitable. As hospitals buy up oncology groups, and then they self-refer. How do we manage this more efficiently? So how do you take innovation and make it beautiful and prevent it from being horrifying? How do we, through our magic pens of creating policy, say, I don't want to cover this way anymore? I use this example of an EKG. You can put a little piece on a smartphone and pay $99 once, or you can send somebody with heart disease, right? The #1 killer in this country, and 33% of Americans have high blood pressure. Or you can keep sending somebody back and forth to an EKG to the hospital, and convenient for them, too expensive for us. So how do we, through our magic pen of policy, healthcare policy and financing, and our collaboration, figure out, we don't pay for this anymore. We pay for that. And if that's an entrepreneur who just invented it here in our community, we're driving jobs. Cool, right? How do we control this? And how do we say to the hospitals, whoa, I want less of this, I want more of that, please. And some of this is sort of neat. Think about reference-based pricing. Reference-based pricing, as you evaluate who is innovating, doing things more efficient, and who is older school, doing things inefficiently. How do we partner with our rural hospitals so we have an efficient delivery where costs come down, what's underneath that cost? And for the reference-based pricing, as we set that attachment point, what's underneath it? And how can we help in partnerships? What I would love to see is more collaboration. So as we have a multi-payer collaborative, how can we get a multi-provider collaborative on the hospital side? How can we use Civic's amazing gifts of data and knowledge? How can we identify who's best at these centers of excellence for every type of elective type procedure? So from colon cancer to a CABG or any sort of heart procedure to those procedures that you like to do and you have time to plan. How can we figure that out and pay those hospitals that are poorly performing a higher profit to partner so they have an incentive to do that? How can we use Prometheus to identify, which John has brought into HICPA, we're so excited. We're going to pay hospitals bonuses for reducing potentially avoidable costs. Prometheus will help us do that. How do we do that? It's a bigger community. So that the hospitals that are poorly performing have an incentive because we ding them with a penalty for poor performance on cost and quality, and too many potentially avoidable costs. How do we create the incentive for them to partner with the other hospitals who do it more effectively? So it's the cost of what you're paying, but it's also analyzing what is the reference-based price? What's the price at which we should be paying? To get at what Bill pointed out, when you have 8,000% variances, is ridiculous. But we have to help our hospitals collaborate. And we have to loosen some of the regulations. And we're not supposed to talk to each other. What are you talking about? We have to figure this out as a community. And we have neat tools like Prometheus that we brought on cost and quality. We have amazing technology, and we can do all of that supporting jobs and building the infrastructure underneath where we understand why that reference-based price is what it is. This is just, top picture is just a recognition of the power of telehealth. This is the Mercy Hospital in St. Louis that built a $54 million hospital with no beds. It looks like air traffic control. There's all this monitoring at home. Amazing solution, mimicking for our rural communities. An amazing solution to be able to teleport the incredible wisdom coming out of university or children's hospital and so many others to be able to share. That partnership where we have a multi-payer collaborative, now we have a multi-provider collaborative, it's huge, huge as its impact. So this is going to get a little uncomfortable in the room. So this is to drive transformation, if you will. Sometimes it has to be uncomfortable. So let's just hit some things head on. You build standalone EDs on every corner. I don't care how much you pay, it shouldn't be done, right? It's one person's opinion. Uncomfortable. A lot of systems say we're leading the needs of the community. Well, let's ask the community what they need, and let's talk about advanced, let's talk about extended primary care or urgent care or other alternatives besides the most expensive, most quality delivery.
Amen.
So the price might be one thing, the appropriateness of care is another. So how do we pay differently to get the hospitals potentially to shut one down and replace it with something else? Right? How do we say, I appreciate that you put that there. I know we had different community voice before. Now we have a different community voice, we have a louder community voice. We sure would appreciate the part of the needs of the community. And then how do we pay differently to say, thank you for doing that. Thank you for doing that. We have something called the Hospital Transformation Program going on right now, HTP. John is in charge of it. Nancy is in charge, Matt, Nancy. So it takes the provider fee that comes, the provider fee that is traditionally just disseminated based on Medicaid volume in the hospital, and allows us to redistribute $500 million in collaboration with CMS based on hospitals' favorable performance, which we then can decide in collaboration with the Hospital Association of Hospitals. So it's getting a little hot, getting a little uncomfortable as these conversations are going on. Where can we agree? Where can we push a little bit to get transformation to the benefit of every employer, every consumer in the state, to do the best we can with that $500 million? Those discussions are going on right now. And these are some of the things. How do we pay you differently to transform that standalone emergency room to something else? Communities. How do we define more accurately what Intella says, which was originally intended to protect consumers? Consumer, you're coming to the emergency room has to treat you. Intended to protect consumers. Now, it's the highest bills, and Donald gets the $48,000 kidney stone. How do we change the rules to say, no, the rule is we pay you to do dual track. Were you supposed to be in the emergency room? Okay, I need to triage you to the next better level of care. How do we pay you differently because you set up that dual track as a hospital? How cool is that? Can we use that hospital transformation, deliver that $500 million across the state because we have hospitals that are cooperating, helping us transform something very inefficient to something very efficient. We have to help them because they get slapped by CMS because they didn't follow the internal regulations. That's not fair either. So how do we collaborate to do that? A couple others, the arms race, I call it, I'll find another word so we can talk about that. The arms race just means if there's too much emphasis on growth and doing all things to all people is not helpful. It's not helpful. That partnership we talked about, Centers of Excellence, Prometheus, paying differently is huge. How do we do that? Independent docs, because of ACOs and other models, bundling payments, your alternate payment methodologies, they start referring and creating their clinical practice pattern reference, whether you're talking about that oncology procedure or whether you're talking about that heart procedure, they create a clinical pathway based on what's efficient. More money that way. But once they're bought by a hospital system, they self-refer. If they don't self-refer, it's called leakage. There's all sorts of procedures for the hospital to get them hospital documents they purchase to self-refer. You have to figure that out. If the hospitals have bought a bunch of physicians, now they're trying to self-refer, they have huge expenses that went out. We have to figure out how to pay them differently so that we get the best bang for the buck. We don't get an inefficient referral practice, we get an efficient referral practice. That's a big deal. And we've allowed a ton of this purchasing to go on. So we got the system we asked for. It's already in place. And we'll keep trying to outbid each other in the exposition room. We're ending up with exactly what we asked for, and this is a problem. Acquisitions, if a hospital buys a standalone surgical facility and starts building a hospital, that's a problem. Yesterday it cost less than tomorrow would cost because of the acquisitions. So as you're thinking about the building you get, okay, it used to be something, now it's something else. Now you get a facility fee, you get a hospital charge instead of the standalone clinic or a standalone physician bill. All of that is impacting some of the prices when you see that 1,000% and 8,000% difference. We've got to get our arms around this. We need to reward the hospitals for not doing this. We need to somehow get the ones under control. Okay, this is a problem. That's why you get so much variation. Prescribing patterns, we all know specialty drugs usually profitable from outpatient hospital. We've got to figure this out, right? So that's the uncomfortable conversation. So now the 500 million, as we have discussions, the importance about collaboration is you're standing in a building with the Denver Chamber. The Denver Chamber has been very vocal about what's important to the employers in that association. I sent the same hospital transformation program negotiating document with the hospital's feedback, our feedback, to get your opinion as the Colorado Business Group on Health. We wanted to know what you think. To change this, we can only change this as a community. Everything that I just said is really, really, really important. Even as much as transparency. When we pay a little more to a hospital that voluntarily gives us financials. We pay a little less because money doesn't. How can we address the things that you said, the chamber said, are important to you, and take the monies and pay them differently? And your input and view through Bob is really, really important. Bob has that document. All of these things are a summary of some of the things I just said. For end-of-life planning, can we pay bonuses to hospitals who do that appropriately, who capture the data, who follow the patient's intentions? Neat stuff. We want to pay more. I don't mind if the profits of the hospitals go up dramatically, as long as the prices to consumers and employers come down. Partnerships can do that. We don't want to beat up our hospitals. We want to create a different system to incentivize them to do things differently. And if they do things differently, reward them. Reward them with higher profits. Profits are not the problem. Prices are the problem. Prices that we pay are the problem. We don't want to shame a hospital trying really efficiently. Therefore, they're making more money. And somebody's trying, right? So let's figure that out. Last slide. I would ask, so we have parallel the hospital transformation program. That is, again, that's in partnership with CMS, the hospital association. How do we pay the hospitals differently using this, the provider fee? How do we disseminate it differently? Parallel to that work stream is a 3 to 5 year plus roadmap of how do we transform healthcare delivery in the state. Lots of brainiacs in a very tight concentric circle. Bill Lindsay's and Jan Del Davis, and, Steve Erkenbrack and me and geeks that spend their whole life doing nothing thinking about healthcare, except for thinking about healthcare. We're so boring. But that's what we do, healthcare, and then it keeps building. Amazing minds inside healthcare policy and finance, you're amazing minds. All the carriers that are helping the hospital transformation group. There's all these concentric circles, these amazing minds that are building this 3 to 5 year plan. I will personally invite you to be part of those concentric circles that are transforming healthcare, because we as a community, the most collaborative community, I would argue, in the country, we do this together. If you want to be part of that, those concentric circles and contributing, I have to do is send me an email. There's my email address if you want to do that. And I want to thank you again for being here today, for being so collaborative, for being engaged. I want to thank Bob for pulling everybody together and being such wonderful leaders. And thank you for your partnership with healthcare policy and finance.
Yeah, no passion there, huh?
That's a tough act to follow, Ken,
Well,
okay?
I was actually going to do Medicaid,
Oh,
the
okay.
Medicare first. Yeah, thank you. So Lieutenant Governor Lynn mentioned alignment, and that's an important theme. And Kim talked about actually a couple of things that I just loved. The current incentives are to be big, not to be good. That's the incentive the purchasers put in place. And in a sense, it's very difficult to cast blame at somebody for responding to incentives that are in the marketplace. And really, I've heard Kim speak to that. No one says that better. The other point is this. It is not, you may have seen the Baumgarten report for the Colorado hospitals. The net margins run in general 8 to 15% net income. And they oftentimes run as high as 40% margins. Anybody making a 40% margin in the group? And meanwhile, by the way, for the public sector, for our school districts, for our public entities, this is double jeopardy, because the more we pay for healthcare, the more we use it. Okay, the less revenue we get, in addition to the higher our costs. So before I introduce, and now you're going to see some really interesting stuff, and you're going to see what the numbers that are driving this. Before I get into that, before we show you Anna, you do need to understand one thing, and I'm going to do this as simply as I possibly can. How do you determine reasonableness of pricing? Well, thankfully, there's actually a methodology. Okay. And that method is provided by a group called MedPAC, which is the Medicare Payment Advisory Commission. Their job is to advise Congress on what is a reasonable payment to hospitals to be able to provide care and to be able to improve quality. Okay, and that's a big piece of their consideration. So the MedPAC group, it's an independent commission, 17 members, primary role, advise on access, member access, and quality, and then particularly to look at payment adequacy. I will not go through this slide. This is not how you create a nuclear reactor. This is how MedPAC, and you have this in your handouts, by the way. This is the detail to which Medicare goes, the lengths to make sure that payment is as fair as it can be when you're dealing with something as complicated as medicine, right? And you can see they do a number of adjustments, including bad debt, teaching hospitals, et cetera. So these payments are in effect risk adjusted, and they go through a similar process, simpler for outpatient. Now, one more word before you look at the results. It's important to understand that MedPAC differentiates between average hospitals and efficient hospitals. These are their criteria for efficient hospitals. And if being in the top 2/3 of class doesn't seem like a bar that should be too hard to reach, just consider that only 15 to 20% of hospitals meet all 4 of these criteria. Okay? And in fact, in Colorado, we're 8th highest in penalties from CMS for hospital-acquired complications. So let me keep going. So here's how, where they look at things like beneficiary access, changes to quality of care, does the hospital have adequate access to capital, wages, they look at just all kinds of things. Here are their conclusions. Medicare as a whole, for all hospitals, pays, hospitals can make about an 8% margin on their variable costs, the costs directly associated with taking care of a Medicare patient. The majority of hospitals do, in fact, lose money on Medicare, and they lose about 9%. Nonprofits lose actually more than for-profits, and as John Bartholomew and I have discussed any number of times, that probably speaks to the differences in efficiencies, right? But here's the point, and this is what's critical when you hear what Anna is going to present and what Marilyn is going to share with you and what Gloria is going to present. Operating margins on Medicare were approximately 0 for the hospitals that hit those four criteria for efficient hospitals. Okay, so they broke even. Now, no one's proposing Medicare payments, but it does provide an empirically based, evidence-based floor or platform from which we can begin to have discussion from charges. So that's what we're trying to do. Now, a couple of other observations. Why do most hospitals, and one of the particular ones that's critical, why do most hospitals lose money on Medicare? And the reason is because you guys are paying them so much. Okay? That's the bottom line. We do not create an incentive in the marketplace to be cost effective. When you pay the kinds of numbers, and that Anna will show you, there is no incentive to be more cost effective. And here's what's driving it. It's not simply horizontal consolidation. It is the vertical consolidation that's taking place in the market every time a health system buys a physician practice. Okay, there are exponential increases in cost. So we're providing them with those incentives. That's on us. That's on us. Those are the incentives. That's how you win in today's market, by getting big, not necessarily by getting good. So and so you have these resources. I'm not going to share with. This was an article that's referenced in the handouts that you have. You can read the article. And by the way, we did give you a number of resources that I would encourage you to read, particularly the stuff from Dave Chase. Really good stuff. And so let me kind of close with this. We know that the consolidation is increasing prices, particularly the horizontal is increasing outpatient prices. Keep that in mind when you see Anna's data. Medicare has been increasing payments, and here's kind of the bottom line. Our household incomes over this 10-year period increased 22%, and our families are paying 58% more. By the way, the prices have gone up faster. So I would close with John Oliver, to use a term from John Oliver. Now this is about our families. This is about our communities. We can't let this go on. This is about our schools. Half of our schools in Colorado now operate on a 4-day week. And who gets hurt? The disadvantaged kids. So now these families not only can't afford health care, but now their kids are going to school 4 days a week, and they have to put a kid in daycare for a day if the parents are working in one of the highest cost of living states. This is not okay. We must do something. All right. So with that, Anna is going to give you some really, really good insights into what's happening. There she is.
You came up too early, so now it's the right time.
All right, perfect timing. So let me, I'll pull your slides up, and if you would just introduce yourself and the APCD.
Sure. So I'll go ahead and start. And first off, tough act to follow, but now we're going to talk about numbers, which is really exciting. Talk about data geeks. We are the core data geeks, and there's a number of us here from Civic. Jonathan, who will help with any very geeky questions. He'll help with those. And we've got Carrie Steph, who really, Carrie and Steph both help to publish the data that we do make public. And then we have a number of others, Pete and Vince and Eddie are here as well. So please, look for us afterwards. Our goal very much is how to provide information to each and every one of you that allows you to develop strategies and make decisions in order to make positive change in healthcare. And I think that's the challenge, is what sort of information is valuable to you, but it's also the manner that we present the information. And that's where we need help from you. So Civic overall, let me get the right one here. So if you look at just real quick, I want to cover, so who is Civic? Very much, we want to empower each and every one of you. And we believe employers should have the exact same set of information that hospitals do, that the payers do, et cetera, in order to be able to make informed decisions. Okay, we're a nonprofit, we're nonpartisan, we work really, really, really hard on being Switzerland. We were formed in basically out of a recommendation that came out of the Blue Ribbon Commission on Healthcare in 2008, and then we became inactive as an organization from a 501c3 in 2010, and then also the legislation for the enactment and the enabling statute for the Colorado APCD also occurred in 2010. Okay, we are a resource to the state. We are a resource to each and every one of you. And the key is, how can we put information in a manner that makes it useful to each and every one of you? Okay, We service right now all of these various stakeholders in different ways and manners. And the goal for us is, how do we reach more of you? How do we provide information to more in each and every one of you? Okay. And I have to say, we do as an organization, and it's not just limited to the females, but every single one of us, we do a lot of GSD. So there is a lot of shit that gets done, and in some days it feels more like stuff, but a lot of days, I have to say right now, we're getting a lot of stuff out the door. And so I think it depends on opinion, and Jonathan, I'll defer to you. Is today shit or stuff? So anyway, okay. So again, you know, the key for us is we want to work with the change agents. We can't tell you what to do. You all have to decide what you want and also how you want to use the data. Focus areas, I think they're fairly descriptive. It's self-explanatory. You know, these are the primary areas that we work and focus in. Data transparency is a big area that we're trying to grow and continue and to be able to expand more on. Data transparency doesn't mean it's all public, but again, it's getting the information in all of your hands so that you're working and negotiating from the same level playing field. Okay. So now I'm going to get into just kind of setting the groundwork for and just some of the basis for the next few slides that you're going to see. And what you're going to be seeing is this information at a fairly high level, and we're only showing you for the commercial marketplace. We know we're not showing Medicaid because, again, what we're representing in the Colorado Business Group on Health is really servicing commercial payers, okay, or employers, excuse me. So we looked at median payments, and where we looked at the actual payments, not the charges, but the actual allowed amounts that were paid either by the member or by the insurance company, okay? We looked at the top 12 inpatient and the top 10 outpatient. The top 12 inpatient represented around 20% of the total inpatient commercial cost, whereas the top 10 outpatient represented 32%. There are thousands of procedures that are performed. This particular analysis represented the highest cost and use, okay? Again, we looked at 12 through 16. We're going to show you a slide that specifically shows the comparison between 12 versus 16, but we looked at each and every year. This analysis, we didn't yet have all of, when we started this, we didn't have all of 2017 in the database. We do now. Our plans are to go ahead and update this. Outpatient payments were compared to the last published, so in this case, 2016 Medicare fee schedule, and then the inpatient was based on the average allowed for the exact same DRGs of Medicare, because we also have Medicare fee for service, Medicare Advantage within our database. The percent Medicare rates reflect the percentage of commercial payments and how they differ from Medicare. Again, focus here is on the commercial market. Okay, as those of you that may look at this, we actually only have 10 inpatient. We're missing the vaginal births with complications and without complications. So those are the two that are missing on this list. But you can see the list of services that are included here. Okay, we'll move on. We looked at the data by region, and then part of the focus of this analysis, of which HCPF is very much involved, was looking at the DOI regions. You know, again, why are the reasons for some of the price variation? Okay, so when we look at the regional focus, it's going to be based on the state's DOI regions. In this particular case, you are seeing the median allowed cost by DOI region. Green is good. Orange is at the other end of the spectrum. There is a $26,000 difference in median prices amongst each of those regions, okay? And this is without complications, so we don't have any of those major outliers in the analysis as well, okay? Now we look at it by a provider, and we actually have all the data. We can look at it in one view from the provider perspective, or the facility perspective in this case. We also can look at it from the payer perspective as well. Looking again at the joint replacement, again, high use, high volume, there is a $38,000 difference between the low and the high cost facility, okay, for the exact same. This is based off their median price, okay? Now we get into the percent of Medicare, okay? So in this case, for the inpatient services, for all 12 of those inpatient services in 2012, the median prices across all 12 of those was 250% above Medicare. In 2016, 290%. Now keep in mind the Medicare rate for each of those years already is adjusted for inflation. So this is above and beyond the those net change in 40 basis points for inpatient. Outpatient, 440% and 520 in 2016. So an 80-point variance between 12 and 16. Now you see those range numbers underneath it. So again, the bold big numbers are for collectively all 12 or 10 of those procedures. Below, if you look at each of those individual procedures, they range from 210 to 300. And then if you look at 2016 for outpatient, they range from 250 to 1,150% of Medicare. Now, on top of that, if you look within each of the facilities, that range gets even broader. Okay, so these are the medians for each of those individual procedures. Again, wide variation. So again, it's important to understand globally and from an overall perspective what the message is, but then how do we go ahead and drill down so that decisions, strategies, and tactics can then be developed and put in place, okay? Are you guys following me so far? I did say data, I did say geeky, and you know,
I love it.
you love it. This is, you know, actuary over here, so of course. Okay, so so everybody, I'm seeing some nods of the heads, so I'm gonna keep going. Okay, so now we go in and we say, okay, let's go ahead and look at Colorado state rate, again, price variation. Now looking at some scenarios, what ifs, okay? And you know, so what my goal is here is to kind of set a picture of what the opportunity, their potential is, and then we're gonna be hearing from Gloria and Marilyn of how they're putting some of this type of information into action. So what if, okay, so we see the current spend. So in this scenario, these 22 procedures represent in the commercial market around 343 million for our subset. We talked about reference pricing, or it was mentioned earlier, Kim did, about reference pricing, and Bob did as well. So if we set a median price and nothing was going to be priced above the current median, what would be the savings? We'd save $49 million, which is significant. As a percent of the total, that's a lot of money. What if we were at 200% of Medicare in which everything was adjusted? That would be $122 million worth of savings under this particular scenario. What if we went to 150% of savings? 178 million. Now, again, we're showing reference-based pricing, which is the median price scenario that's here versus percent of Medicare. Again, we're just trying to lay out different scenarios. There are more that also can be included and be able to explain, but there's two that are listed here. $49 million is a significant amount of savings, any way you look at it, okay? So again, but the range is anywhere from 49 to 178 million. So, Carrie and Steph, you know, we're doing some work on social determinants as well, of looking at how can we take data and help support social determinants and sync up that information and overlay it with healthcare data, you know, because there's a strong correlation, and overall the belief is there's a strong correlation between social determinants as well as healthcare and healthcare costs. So what would 178 million, what could that potentially cover? You know, Bob talks a lot about school districts, you know, so again, a 6.4% raise for every Colorado teacher. It could cover 12,000 students at CU Boulder. Affordable housing units for 890 families. And then 20% of our roads, as there yet was another standstill on I-25 today. Okay, so now let's look at it by region, okay? So there's a lot of conversation regarding, you know, the frontier and how high costs are, you know, on the western slope. For those of you that may have heard, you know, or seen the analysis that we did on the total cost of care, I want everybody to keep in mind that Colorado in the 5-state average was already 17% higher than the other 5-state average: Minnesota, Maryland, Utah, Colorado, and help me, what was the fifth one? Oregon. Okay, so Colorado 17% higher. Inpatient prices, and we looked at utilization as well as price. Hospital prices based on that 5-state comparative analysis, hospital prices were 16% higher. Now, we also have an outpatient facility utilization issue as well as pharmacy issue within Colorado. But again, keep in mind, we're already 17% higher or 16% on inpatient prices in that other study that was done. So now looking at as far as the regions, and what you see is basically a 1.6 times difference between the lowest region being Boulder and the highest being the West. Okay, and again, you can see though that the bulk of the dollars obviously is in the Denver region. Okay, so now we went and looked at and said, okay, let's take the Denver region, or excuse me, the West region. And again, median price, 200% of Medicare, 150% of Medicare. The savings would range anywhere from 9 to 16 million for the West. So now we look at outpatient, okay? And again, remember those really high numbers that we had before. So when we look at it by region, and this again is in total, I believe the net in 2016 was 550% or so, but the range of the costs go from 324 to 694, or a 2.1 times difference between the lowest and the highest. Okay, so now here we're going to look at the East, and again, small region, but again, still impactful for that particular population. And again, the East is the East as the DOI defines it. Again, ranging from $990,000 to 1.9 million. So then we pull in, you know, Denver doesn't look so bad overall. You know, when you look at it from the chart and you look at it, the percentages, but the magnitude of the amount of dollars. So if we look at Denver, the range of savings can be anywhere from $24 to $93 million. Again, methodology, pictures, you need to look at individual procedure that falls underneath it. But again, from a high level, it's impactful, even though Denver did not shine up as a high region for high cost compared to the West or the East or some of the other regions. Okay, we good? Okay, so now we look at an employer case. Okay, so this is one employer. This is their self-funded. We could have looked at it for their fully insured as well. This particular employer has $5.1 million in 2016 that was represented in this particular study. If they went to a reference price in which we picked the median that currently is in, they'd have over $530,000 worth of savings. That's significant. I mean, that's 10% worth of savings. And we showed here, you know, even though no one wants to, you know, we did show on the employer side, what if they went to 100% of Medicare? So again, if they went to 150%, 2.4, but if they were at 100%, which is, you know, again, just for a basis for a picture here, it could be upwards of 3.3 million. Okay, or in this particular case, it ranges from a $45 to a $275 savings per person. Okay. Okay, that's the data. Whew, I made it through. Okay. Any questions before we move on to how people are using it?
How many people got an employer that sample case study?
That particular one was 12,000. Okay. Oh, I'm sorry. Go ahead first, and then we'll get to you, son. Okay. So Medicaid, as far as so on the Medicaid side, actually we're working with John and Hickpuff and where we're bringing in and expanding the analysis on the Medicaid side and actually bringing in some of the provider hospital payments into the calculation. So, you know, I'll leave John to answer that question or to defer.
Oh, thank you. I'm sorry, I didn't even hear the question.
Yes, she asked what you were going to do if there was any savings for the state.
Well, in 2016, Medicaid is paying what Medicare is paying. But we're already paying Medicare prices, which is 100% number or something. So
Yes, yes.
So we could pay less, I suppose, than Medicare, but thanks to the hospital provider fee and other things we're doing, we're already paying Medicare prices. So savings to the state from hospital expenditure would have to come from either incenting more efficiency, trying to lower utilization, navigating clients to the right place, to get care. Some of the points that Tim raised earlier.
Okay. Do we have any providers or hospitals in the room right now? Any of you guys part of the American College of Healthcare Executives? Yeah, one. Because I think that's kind of the next step here. It's really, because I don't know what facilities we have. I sit on the board of the American College of Healthcare Executives. Sorry, I don't recognize any.
Catherine Moretti with the Colorado Hospital, all the hospitals.
Oh, okay, yeah, I'm your membership chair. Yes. Hi. Nice to meet you. Okay, great. Okay, you guys presented a couple. Right? Yeah, good job. Let's do it over. And anyone else? Oh, and then, there you are. Hi, I know you. I think I know we got to get Centura Health more involved with ACHE. That's a whole other conversation. But I think that's half the thing is where's CU? Where are some of the other large providers? I mean, I'd even love to see the VA and the military involved in some of these conversations here. I mean, I don't know. I think that's really where we need to go next.
Yeah, Michael, we're going to talk about next steps when we get to the end of the presentation. We're going to do that as part of the panel. What I'd really like to do is we'll answer any questions. Then we're going to hear what a couple of other folks are feeling. In fact, particularly Gloria has been very, very engaged in collaboration. We're going to talk about some of that stuff. We're going to talk about next steps.
Well,
Okay?
I want to talk about it now.
It's okay.
No, they can't hear you.
It's okay.
The chat is saying they can't hear
Anna, you referenced some savings in your slides, but that's just based on the top 12 inpatient and top 10. So these savings could be a lot greater.
Absolutely.
If these prices are applied to all the hospitals. Okay.
Absolutely. Yeah, again, this is only, and I don't have the microphone here, so, and they're telling us they can't hear us on the phone. So again, the inpatient procedures represented 20%, whereas outpatient was 32. So again, you know, the numbers may change, but all of you can extrapolate, so. Can we? They say they can't hear you over here if we can't get them microphone, yeah. Thanks.
I heard a politician recently saying a campaign speech that it was a terrible shame that half the kids in the state read below the state average. Mathematically, it's going to happen every single day. Here's my question. When we're targeting median prices and reference-based prices, who's going to pay below the median? Who's going to be paying less than the reference base? Because when we're not targeting less, then necessarily we keep raising that floor, right? When we're always saying we want to get down from up here down to the median, 50% has to actually pay below the median. So how are we going to drive the prices down?
And I think that the Medicare, the comparison to the Medicare, those numbers, because they're so much higher than the median reference-based pricing, those in essence bring it well below the median. You know, just to add on to that.
Again, what we're talking about is a fundamental shift in thinking about the way we're negotiating these contracts. Instead of down, we want to use a floor. And we're not telling you that you should pay 100 or 150 or 200% of Medicare. We're not suggesting what the payer should pay in the marketplace. That's up to the buyer to decide in a free and robust open marketplace what you should pay. But you should at least know how reasonable that payment is, okay? And what we're arguing is you have no way of knowing. Now, there is a danger, David, that you kind of point out in all this, and you'll hear about this from one of our speakers. Once you have these data and you know what's being paid in the marketplace, if the employers themselves are not willing to do what I just said, then the people on the bottom are going to want to go up instead of getting the people on the top to go down. So that's the danger of information, right? Every sweet has its sour. And the question is, will the purchasers behave like purchasers and begin purchasing healthcare, not simply paying for it? That's up to the purchasers. What we have today is because the way we've been buying healthcare for 50 years. We'll take one or two more questions, and then I want to take just a short break, give you a chance to run around a little bit, because you are going to hear an incredible story of what's happened, and this is not a theoretical exercise. You will hear what's happened in the state of Montana when they use a Medicare Plus model. And then you'll hear from Gloria about the kind of collaboration that's been taking place once the purchasers have a resolve to actually do something. So one or two more questions, and then we'll break.
Dr.
David Keller at CBGH, sorry. I'll take that. So one of the other interesting things I always think about is that our payers, our insurers, are insuring people in both rural and urban areas when they're writing their policies. Kim, actually, all of you have pointed out that that the systems are different. They need different policies. Kim was talking about perhaps moving towards local payment out in rural areas, things like that. So instead of modeling different rates, I'm wondering, have you done any modeling using this data to look at what the impact of, say, a global payment on a rural hospital would look like, and how you would make that work to try to deal with some of the instability in rural hospital funding?
I couldn't have had a better lead-in. Thank you, Dave. So some of the things that we've implemented, Kim had referenced before, Prometheus, which is a bundle methodology. We now have run that data, and it's taken a long time. We're one of the first, if not the first APCD that has ever run Prometheus against its entire database. So we have run it for all of commercial through 2016. We're running 17 now. Medicaid now has been run through 16. I'm not sure if we've done 17, and we're also going to be doing it for Medicare as well. So yes, that is, so our intention is some of the pricing that we're going to be rolling out on the public side for both inpatient and outpatient procedures is going to be based on the bundled payment. In addition, we have a regulatory change, because again, our data submission guides, we have over 70 submitters that are submitting data to the APCD on a monthly basis. They adhere to a data submission guide, and that goes through a regulatory process, an annual regulatory process. We are in the process of adding APMs, alternative payment methods, of which, so we can also understand and what is currently being paid. Now, granted, it's a small percentage of the total, fee-for-service definitely dominates Colorado payments, but we'll be able to analyze as well as put data, into basically into more of a bundled type format as well. So.
If I could add on to that, this is important because Kim mentioned Prometheus, and John brought it for the state for HICPUF. And Civic has it for Civic. And so it can be used both for analysis and actually budgeting, but then it could be used to align payment mechanisms. Now, for some of the more advanced states, Tennessee, Medicaid and the commercial market, including the health plans and the largest self-funded payers, they actually come together and they've agreed with the health systems about using bundles. And they're putting in place or developing up to 75 bundles, which creates very, very different choice architectures for providers, okay? So there are alternatives, and Michael, we will talk about what to do, but first we have to get at whatever we want to use, we have to understand what the basis of what goes into those bundles, because in the end of the day, as my actuary friends used to tell me, this is all about unit use times unit price, right? That's what it's about. It's about unit use times unit price. So, and both are issues. We're going to talk about price today. So let's take a break because I know with this crowd, it's going to take us a little bit. At the latest, we want to convene at 1:30. And coming to order. This is almost, this is actually easier than calling a school board meeting in order. So, again, thanks for coming together. I'd like to begin with one comment that's critically important, and in a sense, it introduces our next speaker. Kim Bishopper pointed out that hospital costs is roughly 40% of the medical expense risk, right? So guys, think about this. If hospital costs are 40% of medical cost rate, and if what Anna said is that 150% of Medicare cuts them in half, you can cut your costs 20%. It's a 20% cut, if not on the whole premium, because there's an administrative cost there that I'm not accounting for. You can cut on 85% of your spend. You can cut that by 20%. That is not insignificant. And in fact, that's in part how you get to those the teacher raises that I pointed out. We I don't know who it was. I don't remember who. Oh, Francois Lebrun from HCI3 had posted something, if you know Francois, something about let's follow the leaders in the country. And he highlighted that, or he led that blog by pointing out what's happening in the state of Montana. Now, I have to be honest, in all deference to our next speaker, that's not where I would have looked. And I appreciate it, but I wouldn't have said, oh my gosh, let's go see what they're doing in Montana. But as it turns out, it's pretty significant. And so the lady that is going to take the podium is going to tell you a story that I think is one of both innovation and, very frankly, courage. Okay, this is the kind of courage that purchasers need to execute. Now, this lady, Marilyn, is a CPA, an actuary. I work for Blue Cross Blue Shield. She knows the numbers. Okay, and she has been incredibly effective. And so, Marilyn, I'll turn it over to you. And thank you so much for being here today.
Thank you very much, Bob. I really appreciate this invitation. I'm humbled being here. All the brain power in this room, far beyond mine. I think I'm very, very fortunate to be here. I am the administrator now for the State Employee Health Plan of Montana, and I hope I can figure this out. I did. We have about 31,000 lives, which doesn't sound like a lot when you're talking your populations, but we are the largest self-funded health plan in Montana, and we have members all over the state and in small places, urban, whatever. We are self-funded on our benefits. And let me start off talking about what brought me to the state. I've always been in private industry. I've been a CFO for TPA. I was a controller for Blue Cross Blue Shield Montana. I've been superintendent for gold mines. So I've done a lot, but it was always financial focused. And I was getting to the end of my career and I was ready to retire. And I was recruited by the state to come in to try to turn the health plan around. I thought, well, that might be kind of interesting. I've always been on the other side. I've never worked for government before. I wasn't familiar with procurement processes. I wasn't familiar with all the players, so I had a lot to learn. I was hired in September 2014. In December 2014, the actuary produced this report for the legislature. He said, your report is being mismanaged. You're not spending the money appropriately. You have numerous vendors, and if you continue on the trend that you are at, your reserves will be minus 9 million in December 2017. So I was hired to turn that around. So one thing coming into the state government that was really different for me are all the pressures you have from every source. You guys don't have pressures? Oh, I do. I was surprised. First thing Montana legislature did in winter of 2015, I had just arrived, was they passed Senate Bill 418. And Senate Bill 418 said, we will give state employees a 50-cent an hour raise for each year of the next biennium, conditional upon the state health plan implementing cost containment measures and bringing the plan back to a good point. And everybody was on board with that. So I had legislators mad at me, and not to mention employees. And employees were mad. What has happened? It's our money, and it's, you know, bringing up attorneys on ERISA law, but we're not in ERISA plan. But the news media covered it. The governor's office was putting some pressure on, but they had my back. They said, we're going to help you get there. So vendors, providers were upset. They were upset for the condition we were in, afraid they'd lose their contract, and even better, they all had another product to sell us that would save us. Brokers, unbelievably knocking at the door. Sorry, all of you, I think I will offend everybody. The Montana hospitals were out lobbying the governor, you name it. There was a pharmacy product we had called URX that was developed through a purchasing co-op that they knew I was going to look at. Plan members, unions, our own staff was upset. I learned that change isn't that easy. And I then ended up with 28% turnover. And it was all attrition. It's just hard to bring change into a plan. And we were running out of money. So the first thing I did was get into the data, which was really hard to get to. It just didn't exist. There was no data warehouse. I had to contact vendors and everything went through their filter, and I was just having a heck of a time. But once I got the data done, I did ask our contracted actuary to verify it for me, just make sure I was on the right track. And we pulled this together, and sure enough, Montana hospital facilities, inpatient, outpatient, 43% of our spend. I knew I had to hit there first. The next one, pharmacy, 18%. Now in Montana, what gets the most publicity is the legislators and the hospitals hate our on-site health clinics. We have 5 in 5 different cities. They hate it. And I think what we've been able to do by putting them in is really restrict or put a gate on that referrals, the downstream care. We've been able to change that. But these were the 2 areas I hit first. I thought if we're going to make savings, we need to do it there. So just to get the point past the legislature, this is embarrassing. All of you guys know what this chart is, but I was educating the legislature, the governor's office. And so I quickly went back and looked at the semi-private board and room, charges to the state plan, billed and allowed. And what I was trying to show is we're on this trajectory up regardless of what discount. You may be really excited that this is going to be a 12% discount versus a 10%. Wow, didn't we really show them? And so I have struggled with this from day one. Even when I was at Blue Cross Blue Shield and provider networks are the big thing, it never made sense to an accountant. So I used this to try to say, and I unfortunately didn't put the chart in that I was able to kind of put the Medicare rate into. But with this, I was able to talk to the legislature in April before they finalized Senate Bill 418 and say, could you put in that bill a requirement to look at reference-based pricing? And I want to find out a different payment method. And it was lobbied very heavily against by the hospitals, very, very heavily, right up to the end, and it passed. So whatever leverage that was going to give me, I wanted it. The first thing I did was rerun 1 year's worth of claims through a Medicare repricer. We used Payer Compass and we ran 1 year worth of claims through. And of that 43% of the Montana hospital spend, 87% of that are these 11 largest hospitals, our acute care. So I thought, that's a good starting place. So you need to have the data. Oh my God, do you have the data? And in fact, I'm embarrassed about my simple little analysis here, but I charted this out, and you can see for outpatient, we were running from 230% to 611%. These are for the claims, and we repriced every single claim, or the Payer Compass did. And once I had this, I could kind of see where we might be able to change things. The next thing was on inpatient. And what you can see here, the low was from 191 clear on up. Something interesting that Bob had talked about before, this hospital right here, this is the only for-profit hospital in the mix. And it wasn't until I was talking to Bob that I was able to connect those dots to realize, and that they're the lowest on the other one too. And their quality measures are right up there, they're good. And I thought maybe there is some sense to this, that instead of listening to the hospitals say, well, we have to charge more because we have so much Medicare and Medicaid. Maybe the reverse is true. And Bob helped me see this. Maybe because if they're not for profit, they don't have to please shareholders. They don't have to they don't have to please shareholders. They don't have to be that efficient. They don't have to keep their costs in control. They just keep raising those prices. So that has prompted me in one city where this hospital is. There's another one that's one of the higher ones there. And we're starting to do some analysis on the profitability there to see some relationship. So I started going to the hospital. Oh, this is the best one. Once I got all this together, I started working with our third-party administrator and asked them, could we go to the hospitals? And I don't want true reference-based pricing where there's a potential for balance billing. I want contracting. The last thing the governor needed, it was an election year. The last thing he needed was, to have a lot of members with large balance bills. So I wanted contracting, and I knew that if we did that, we'd have to come up with a little bit higher rate than the 150, whatever. If I go back to these slides, what I tried to look for was a sweet spot. What kind of a spot is in there that if I could just get to that point, what would I say? So we looked at outpatient. There was this area at around 250%, which shouldn't cause too much disruption. And we could go to the hospitals and say, we didn't tell them the names of the hospitals. We showed them this and we said, now, in our mind, these are really efficient. They're running well, their quality scores are great. What about you coming down to that level? And those were tough conversations. I'm not going to say they weren't. And I did the same here. It looked like around 220. Actually, we were going to go to 200 because we have these two here. But through negotiations, that didn't stand up. Well, the first thing the hospital said were, we don't trust your analysis. You don't know what you're doing. So I said, that's fine. I'm new at this. And so I'll give you all the data. It's, identified by the numbers of the hospital. We'll give you all the claims data. And they said the only group they trusted were Cleverly and Associates. So we said, fine, let's run it through them. And they do hospital payment index is what they do to see who the outliers are. So I did an overlay here. The darker blue is the Medicare repricing study that we did. And then the allowed charge index that we had, and then their study. And absolutely, it lined up. I was so surprised. But I wished I would have my slides done because I was on my computer today reading some things that Cleverly and Associates have come up with about hospital strategies that I don't quite agree with. But I wish I would have brought the page because in big orange letters on their site, they spell hospital wrong. People spell it H-O-P-S. Oh dear. So I think, but I like their numbers. Their numbers confirmed our study. So then I was able to go out to the hospitals and say, you know, we did this with your data, analyzed everything, and everything's falling in line. So I asked our third-party administrator to help me. Because of Montana procurement rules, I can't do direct contracts. I would have to have a third party do that contract. I approached the Healthcare Purchasers Association we had, and I said, I'd really like to do this as a group because we have the university system there, we have all these school groups. Let's do this as a group. And they were not interested, nor were any of those employer groups, because they're brokers or their carriers were telling them, you're already getting the best price. We don't know what the state's doing. And nobody would help. Well, the carrier we had at that time said, no, we don't believe in this reference-based pricing. Our networks are better than anything you're going to get. We're not going to do this. So this was a lot of work. And here we were, July 2015. And I said, well, that's fine. We'll just do an RFP for another provider. So I did that, and we had 9 respondents. The respondents, 3 flat out said reference-based pricing is stupid. There's no way we can get better discounts. So I kicked them out. Then we had one that said an ELAP model, and I think probably you're familiar with ELAP or AMPS. That's not going to work, and it's not going to work with the state of Montana. With all these rural areas, it's not going to work. We had a couple of them say, well, we'll build you a narrow network, and the discount will approximate where you want your targets to be. We only have one TPA who said, yeah, we'll work on this with you. We've been doing some of this analysis on our book of business too. So obviously they got the contract. I then sat through, which I didn't know about the state government, I sat through a protest. How do you say we just don't want you? You can't do that, state government. So we weathered the protest, and I pushed. We were able to bring the TPA on January 2016. And we didn't have the reference-based pricing agreements involved because they had to go through the TPA. So we then started negotiating face-to-face with every hospital. And it was not easy. But I'm proud to say we have all hospitals signed. It was not that easy. We said we're going live with this July 1. And I think the hospitals thought we'd back off, but we didn't. And so we put in a travel benefit. The TPA beefed up the case managers so they could help move members with their care. And we went public. We didn't name names of hospitals, but we said, these are the hospitals that won't sign, and these are our graphs. They're way up here. And gee, we got 4 of them to sign. Well, that was pretty cool. And then we had, then we had 2 that were just standouts, but it was cool because the one, and it made the press, so I can talk about it, was Benefits Hospital in Great Falls. He had gone on a long campaign of the CEO of talking about how he makes a profit at Medicare. He's so efficient. So why would he get upset that we're trying to bring in 220 to 250% range? So we hit him back with the press, and he brought out all guns. The same with another hospital in Missoula, and we were there getting employee presentations on June 28th, talking about the travel benefit, working with employees to move their care. We were about in the 3rd meeting, and we got a phone call that they decided to sign. They had 2 members, and the case manager from the 1st meeting approached them, and they were moving their heart surgeries to Spokane, Washington. It was cheaper out of state. So we got them, but Benefits just hung in there and fought. They then went to the press and said, well, we can't do this for the state because Blue Cross Blue Shield is our very, very best carrier, and we never give anybody a discount better than we give Blue Cross Blue Shield. So we said, fine, we put the travel benefit in, but we had members angry, legislators angry. Oh, the other thing I learned, legislators that hammered us on one hand for the health plan costs and telling us to get it in shape, they sometimes sit on the board of directors of these hospitals. I didn't see that one coming, and that was my situation in two of them sit on in the one in Great Falls. So we ended up, he signed August 2nd, and it could have been a little bit of research in the 1990s that helped that he was a, now this is not probably much for Colorado because your cost of living, but Montana is still very rural. And we reported, you know, it's too bad they can't budge. His salary last year was 1.8 million plus bonuses. And you know, the governor, bless his heart, he stood by me the whole way, and it was an election year. And the budget director, phenomenal. I couldn't have done this without the budget director, and my administrator then, Sheba Hogan, was phenomenal. I learned how to negotiate from her. You never believe. We walked in, and I'm sitting there working my numbers, and she said, well, there's no use sitting here anymore, we're leaving. And we walked out of a hospital in Billings, and I'm running behind her. Oh my God, oh my God, we can't. And I'm just panicking, and I said, what do we do now? And she said, we go to the mall and shop. And that's what we did. So we ended up, we were very, very careful with critical access hospitals. They are critical to rural Montana, just as they are to you in Colorado. And we didn't, but they were already within range. They were fine. There were 3 that weren't, and those 3 are actually owned by one of those large hospitals, and those negotiations were tough. We have 3 hospitals yet that haven't signed, and there were annual spend of $10,000 to our plan, and our plan is $200 million. So it is cute. It's rural Montana. It's that they can't get the controller and the board president there because there's flooding and they have farms and ranches. I mean, we're talking about these little tiny towns. So we left them as is. But for us, it was reference-based pricing. It's reimbursement right across the board. Your J-code specialty medications, your implants, you name it, right across the board. And we're using the DRGs. One thing that we found is length of stay dropped. And we had a particular case where a member was going into the hospital every year for 3 to 4, sometimes 5 months. And it really bothered me when I talked to the billing clerk one time to negotiate it. And she said, well, she's one of the people we warehouse. I wasn't familiar with that phrase before, and I don't think she probably should have said that to me. But it became something I used frequently. And, and so we, where that person would stay there, that individual, we were trying to do day by day medical necessity was the model we were under. It's not that. Now, when you do on Medicare, we send all the claims out to Medicare repricer, and we come back and they're paid by the TPA as a percentage of that. But it works on the episode of care and it's limited. That person's been in the hospital over the last 12 months twice, and the longest stay was 1 week. We have saved hundreds of thousands on that, just that one case alone. So this was our strategy, and it worked for us. I'm not saying it's perfect, but that was our range of the inpatient, outpatient blended rates. And that's where we started. Now, some of the hospitals that were really high, we put them on what we called a glide path. We'll let you come down a little bit lower. We negotiated them differently, so that by the time we get to 2018, we would narrow that range. So our strategy was, let's get those high payers down to what we call the efficient, but not the right efficient definition with that. So it's been very successful for us. This was our projection, and we've exceeded it. A couple of things here was we looked at without, we called it transparent pricing to start off with, then we thought, ooh, that's a bad thing. It's not really transparent. So we called it reference-based pricing. Well, it's really not, because if got contracts, so now we're calling it contracted reference-based pricing. But we put it in place July 1st, 2016. Hospitals are phasing in, and so we have that immediate savings. But the other thing that's interesting, because we're capped at the percentage over Medicare, that increase is not on whatever the charge master might be. You're not going to have 5, 6, 7% increases. A couple of the hospitals, we did go to medical inflation instead of just Medicare, which may be 1.5%. We went to CPI medical, and maybe it was 2%, but we've been able to really cap that. So this is what happened to us. We ended up 2017 with 112 million in our reserve. And I was really pleased. Now, there's other things we did too, but the bulk of it is reference-based pricing. The interesting thing about this, and the actuary has verified all this for me, these are his numbers. I was so excited about what we had achieved. And so we also through this time, we raised rates, employee contributions, and we changed the out-of-pocket in 2016. But there was no rate increase in 2018, no change to out-of-pocket, none in 2018, and we're projecting through 2020, no change to the employee contribution, and no change to the employer contributions. But the thing I didn't realize is that we suddenly had more reserves than the state of Montana general fund. I didn't see this one coming. It was a tough fire year, as you all well know in Colorado. It was a tough fire year for Montana. So Montana called a special session in November 2017 and passed Senate Bill 3, and 25.4 million of my reserves are now with the general fund. But I was glad. If we could help out the government somewhere else, that's it. I'm glad. But there's other things we did. Big time. I tore apart the pharmacy contracts. I found unbelievable stuff. You know, they were saying we're getting 100% of the manufacturer rebates. Yeah. But did you know drug manufacturers have admin rebates, marketing rebates, you name them? I tore apart those. We were paid an admin fee. We thought there'd be a spread in, or we didn't think there'd be a spread. There was a spread. We went out with RFP. We had 7 respondents. Only one of those respondents would do the model I wanted, which was fully transparent that I could audit. We just finished up the year in 2017. We went with the new product. We had better care for our members, and we saved $7.4 million. And the AWPs were pretty much the same. Well, in fact, they were right in. And I'm paying lower admin fees. I'm paying lower admin fees for no spread. We changed our TPA. We did a lot of benefit plan modifications. The SPD had not been updated since 2011. It was not compliant with ACA, so that was a 10-month project. And we standardized a lot of the benefits with an appeals process. No longer could an employee call the department and say, I want to go to this specialty place for my surgery, but it's not in network. And the department previously would say, fine, pay for it. So we did tighten down on benefits. But I think that's more fair in the end. You're touching everybody's life, not just those that complain. We have our on-site health clinics. We've been able to work that through that the average appointment there is costing, well, they do a lot of different things. So there's a lot of different CPT codes. 2017, the average cost was $90 per visit. The actuary compared it with the CPT codes in the marketplace, and the plan span would have been $155.22. So we really saved. We did a really good lab contract because previously the labs were done by the local facilities. We did one lab contract with a Billings clinic in Billings, and first year we saved $1.7 million just on that lab contract. And we kept it in Montana. I eliminated a lot of duplicate vendors. We have 4 wellness vendors. We've moved it all under the clinic now. I renegotiated vendor fees anywhere from an 18 to a 24% reduction because they were way too high. What is it? People think if you're the state, you're just this empty pit of money. You know? And probably the thing I'm most excited about is our medication therapy management program. We went to, which some of you will know is an AGWIP, Employee Group Waiver Plan, instead of the RDS system for our retirees. So we're able to access CMS reinsurance, and we're able to get coverage gap discounts. We've done very, very well on that, and our retirees are getting the care they need. But with an AGWIP plan, because it is a Part D with a wrap, you need to have an MTM program. So we just purchased the plan that the PBM offered. But I didn't really like it for our commercial population. So I've been working, and it goes live July 1 with Montana Family Pharmacies. We have 113 independent pharmacies in Montana, and the University of Montana Pharmacy School. And we have developed a program that they will administer a care plan, working with the provider and the member, face-to-face contact, face-to-face monitoring. We have a diabetic club and an asthma club, because those seem to be some prevalent issues, where they are working directly with the members. They're monitoring them. The pharmacy students are in our health centers working with them. And now I'm trying to get the independent pharmacists to be able to put a pharmacy in the Helena Health Center. There are no independent pharmacists in Helena anymore. They're all big chains. So we are in the last steps of getting, of course, it's getting pushback from the hospitals. But now this is what happens, so I'm not going to whine too much, is our current plan projections for the blue line. That's where we thought we would be, because we're still bringing in some savings on reference-based pricing, and we're not done. We're going back out now with lowering the rate. But this doesn't include that. This includes no increase to employer contribution and no increase to employee contributions. But we feel we're fine, because even with the legislature taking the 25 million, we're still projecting to be at 100 million. Keep that reserve there. And the required reserve for the actuary, he's pricing it at 80 million. So we're still well above. That's our story.
Well, I told you it would be a good story. Marilyn, thanks so much, because, you know, it's sometimes hard to envision what can be done, right? And oftentimes that is the biggest barrier to making progress. So thanks very much. We will have a panel in a little bit for questions and discussion, and Marilyn will be on the panel, but I do want to, without any further delay, get on to Gloria. Gloria was actually, as I mentioned, the first employer group in the country to do this Medicare kind of Medicare Plus assessment, and really kind of inspired us to get on this path and think this way. So she's a much nicer person than I am. She's been so collaborative in the state, and so she'll give you a sense of what she's tried to do to bring the parties together and have some constructive discussion. So Marilyn, I'll turn it over to you, and I'll pull your slides up.
What a group. You guys are just tremendous and amazing. It's just so impressive that we have over 100 people here today, and thank you for allowing me to be here. So my name is Gloria Sachdev. I have my doctorate in pharmacy by training. I was actually a provider for 12 years, managing patients with chronic disease states, diabetes, hypertension, hyperlipidemia, and coag clinics. I was interested in how services got paid. You know, like who makes the decisions? How do they calculate return on investment? Why do these services that seem to be really improving patient outcomes, they don't get paid? A whole bunch of services that seem to not add any value, and they get paid a lot. So I stepped out of a direct patient care role in 2009 and did some consulting around the country, and that was going pretty well. But I had 3 kids, and I was missing too many birthdays, and just missing too many flights to get there on time. And one of my roles was being a consultant to the Employers Farm of Indiana. And so in 2008 and 2009, I was a consultant to them. They had a little project called electronic prescribing, e-prescribing, which was a non-thing back then. And so they asked if I would help lead that initiative for the Employers Forum. I think I was the only pharmacist that Dave Kelleher, who's the founder of the Employers Forum, ever met. I had never worked in retail. I didn't know anything really about e-prescribing, but my learning curve was like that. And we went from 33rd in the country to 8th in the country in about 18 months. And so e-prescribing, for those of you, you know, who may not be familiar with it, when you go to your doctor's office and they say, what pharmacy do you go to, like your prescription sent to? And then they send it, and when you go there, it's ready. That's e-prescribing. So it was to get away from handwritten prescriptions. And that was really an employer-led initiative in the state of Indiana. So our employer group is multi-stakeholder. We have hospitals, health systems, providers, health plans, self-funded employers, health information exchanges, and academics, and other interested parties. We meet every 2 months as an all-stakeholder group like this. We have 80 to 100 folks every 2 months. For the real popular events, over 100. And we work collaboratively. You know, we have to work together to get anything done in Indiana. Montana, apparently, you could just do whatever you want and be amazing and totally kick butt. I'm bringing her out, by the way, in November. So, as an N of one who can just really move things. I'm not finding it to be as easy to do that in Indiana unless we work collaboratively. We have very high healthcare costs. We have very influential, I mean, our healthcare system it completely works the way it's been designed to work. You know, it's very inefficient, very ineffective, very costly, blah, blah, blah. And so we just all have to kind of roll up our sleeves and figure it out. So we did an initiative, and I don't have a whole lot of fun. Oh, I don't want to. So I guess let me just start with this. Okay, so let me find the, there's three screens here. All right, so just to back up what we decided to do. So Cummins is a Fortune 500 company. They're part of the forum. So is Chrysler, and so is Roche. They came to me and said, you know what, why are the prices so high in Indiana? They're so much higher in Indiana than everywhere else. I'm like, really? They are? I didn't know that. So I did a literature review, being evidence-based and going to the literature first, and found out that there were very few studies that really compared prices. There was some work by a gentleman named Chapin White that was at Health Systems Change. He got some autos data from Chrysler, Ford, and General Motors. You guys see some head nodding, you probably know him, know of his work. He compared 13 markets in the autos, and they looked at prices relative to Medicare. No, actually, they just looked at prices, not relative to Medicare, comparing prices. And Indianapolis and Kokomo were the highest for outpatient in the 13 markets, and we were second highest only to Kansas City for inpatient. So that was the only evidence we had that we were high. So we had to do a study. We needed to better understand this space. We just kind of fast forward, we came up with an idea, read a bunch for about a year, noodling like, how could we bring price transparency? We need real price transparency in this space. We thought, and you heard the reason why from Bob's presentation, that using Medicare is a really great base. When you use Medicare, they take into consideration a lot of factors, right? There's that MedPAC committee we talked about. But they take into consideration how sick the patient is, like they call it acuity, right? How acutely ill that patient is, how many complications they have per visit. They take into consideration where that hospital is. So they look at local wages. They take into consideration DISH, which is another adjustment that they make, which is the percent of the underserved patient population that that hospital is serving. They take into consideration if they're affiliated with a medical school or not. That's the IME adjustment. So they have all these little adjustments. So if you are a hospital that's serving a lot of Medicaid patients, you're affiliated with a medical school, you are in a really high cost area, and you see a lot of sick patients that are chronically ill, you get paid more for that hip replacement, that knee replacement, that heart bypass, that colonoscopy, whatever the procedure is. Medicare will pay you more than the hospital who doesn't have all of those things, okay? So it becomes a fair way, because our hospitals always tell us we have the sickest patients. You know, our patients are sicker than anyone else. We see more, you know, we serve the Medicaid population more than anybody else. We're the largest medical school in the country, and so all these things. Anyways, I'm like, okay, that's all good. And thank you for doing that. But the factors are all adjusted in the Medicare price. You get paid more because you do that. So when we compared commercial prices to Medicare prices, It's fair. It's a fair way to use Medicare as the denominator. However, there are these gag clauses that are in place between health plans and the network providers they sign in. So all the hospitals and health systems, Anthem Blue Cross Blue Shield is our largest commercial payer. We have United second. So Anthem has 60% of our market share, and United Healthcare has about 23%. So they can't share, they can't talk about it, the hospitals can't talk about it, the doctors, the health plans, nobody can talk about it. The employer's like, we want to know what we're paying for, too bad. You just keep writing the checks. So what we did was we decided that employers own their own data. That's number one. Employers own the data. The health plans don't own the data. We established that through a Gaslight fight that we had with them a couple of years ago regarding who owns the data. Employers own their own data. Number two, we had a one-page authorization sheet that the employer signed saying, send my data to RAND Corporation, and they're going to be just a vendor, like a research vendor, like any other vendor that the employer has. And they're going to do an analysis for us. And that analysis is this price transparency study. So the price transparency study in Indiana, this is what we ended up at 14 self-funded employers. We had data from mid-2013 to mid-2016. We had $695 million in claims, about $700 million in claims over that 3-year period, about 225,000 covered lives. Okay, not a huge number of lives, more than 31,000, but not a million. And so we had a good number, and here are the results. And this graph is just one sheet. This is my favorite. I can outdate you, but I won't, and I only have one data slide. So Parkview Health, and so what we did, I forgot to say, this is the first hospital price transparency study in the country where we did prices are reported as prices relative to Medicare. So are you 200% of Medicare, 300% of Medicare, 500% of Medicare, 611% of Medicare? What percent of Medicare are you? And we put the hospitals by name and published it publicly. We did inpatient prices, outpatient prices. Within inpatient, outpatient, we broke it down where we could if we had enough claims data. ED visits, imaging, whatever. This report is publicly available to all of you. You can go to the Employers Forum of Indiana website. You can go to the rand.org website. On the forum, we have a press release and has a link to the study. You can go right to rand.org and type up Indiana Price Transparency Study, and it'll pull up. It's free. You'll see all the hospitals, 120 hospitals by name, written out, and then what their prices were relative to Medicare. So we decided, we shared this in front of all of the hospitals, and I met with all the CEOs ahead of time the week before I published it, and I said, you need to get press ready. Here we go. So Parkview Health is in Fort Wayne, Indiana. They had no idea that they were such an outlier on prices. These are prices paid, allowables. They only had charge information. So they knew from charge masters, and the Hospital Association has a database that's available to the public on charges, but who cares about charges? Nobody pays charges. It's all negotiated rates, right? So it's like going to a hotel, and on the back of the hotel, it says $568. You can pay $568. You pay $232 on Orbitz, and that's what you care about. You want the best deal you can get, not what you don't care about charges. The only people that are paying charges are the complete uninsured, which I'm really glad to hear that in Colorado, you have a safety net for your uninsured, but we don't. Okay, so in Parkview Health, they were the highest, and this is our trend. And you can see this is a trend away from Medicare. Trend away from Medicare pricing. So while our average over a 3-year span over 120 hospitals is 272% of Medicare, you can see some of them are 4 and 5 times Medicare, and all of them are trending up. This is a year and a half ago. I don't even know where we are right now. So we're going to redo this study. And we are inviting the whole country to participate in this. Woodward Johnson Foundation funded this study $105,000. They're contributing another $105,000. We are inviting, because the hospitals, when they saw this, like, yeah, we cost shift. We have to cost shift. We can't live off of Medicare and Medicaid. So we cost shift to you. And the question is, what's fair, right? What's fair? Okay, is 150% fair? Is 175% fair? Is 250, 450, what's fair? They said everybody cost shifts around the country. So this national study, the point of it is, you'll get a report like this, the employers who financially contribute, and we're asking, 20 cents per member just to contribute. So it's very, very nominal. And it all goes to RAND Corporation to do the analysis. And then if you're an APCD like Colorado, there's no charge. There's no charge. We'll just let you dump all of your data into the analysis, and you'll get it because your data's clean. There's not a lot of work that has to be done. You mapped all the hospitals. It's easy. And so we have 15 business coalitions around the country that have already signed up to say they're really interested in it. We're enrolling now. This report, the national report, will allow it'll be the first national hospital price transparency in the country. You'll have benchmarking. So you're high here. I think you're really high based on, I don't know, based on the very limited information we have around, hips and knees and things. But we looked at all prices, all inpatient prices and all outpatient. If you don't look at everything, you focus on 10 or 12 things, inpatient, 10 or 12 out, you will see prices lower in those areas. They will pop up somewhere else. They will pop up in C-sections. RBB only works if you look at everything, okay? Look at the whole pie. And so this will allow you to benchmark within your state. This will allow you to do some benchmarking in, around the country. So I just have one other slide. Let's see here. Okay, so what did we talk about? Employers got this information, and while you've heard what Montana's done, which is phenomenal and which is on my list of things that we could do, this is what we're talking about doing. So our employers are actively trying to figure out, we have price data now for the first time, comparative price data. What do we want to do? Some of them are doing direct negotiations with the hospitals. They have on-site clinics that are by the hospitals. They're like, hey, I thought we had a really good relationship. What's up with this? I can see your prices right here are so much higher than everybody else's. We're going to move. You need to come down. Easy discussions. Centers of excellence, we heard about that. On-site clinics, we're getting a rapid increase in on-site clinics from employers. Every health system has developed a new business line called on-site clinics. So tiered networks, reference-based benefits, narrow networks. A lot of discussion in this space. We have not spent very much time on number 3, but we will. It's called plan accountability. We are really excited to partner with our health plans in this space and demanding that they develop value-based payment models. Okay, we need to identify an appropriate set of quality measures and align payment with it. It's not complicated, right? We want to pay, we want best quality at best price. Simple. We don't want to go to lowest price. We want best quality at best price. So we really need to understand quality. And so Anthem is developing, and Anthem's here. We're one of the 14 states, so are we. They're developing a new value-based payment model that will launch in 2020. So maybe Bob can bring some folks in and they can talk to you about it, since I'm under an NDA. And I will say, we are partnering very closely with them in developing that for the country. We're working with Anthem Corporate, and we're working with our Anthem President and all of the VPs. We've had 12 employers meeting with all of them on a monthly basis around this, and the directors of quality, but lots of work still to be done. Percent of Medicare, Montana is doing that. It's an amazing idea, I love it. If I could do one thing, a simple payment model would be percent of Medicare. Pick whatever it is and let's incent around that. Hit the quality measures, you get a 25% bonus. Get 250, you go to 275. If you don't hit those performance measures, you get a 25% deduction. And now we're competing on, it's a 50% spread. You will see hospitals and providers highly motivated around achieving those patient outcome measures. And I say patient outcome measures because we've had a whole other group of 25 folks that have been meeting together, and we'll have this report available, but we had all the hospital VPs come in of the largest health systems, and Anthem and United, and a bunch of employers and hospital associations, and we said, of the hundreds of measures that are out there, I need a reasonable set of measures that we can align payment around, and we came up with 21 measures. So it's amazing that they did it. It took them 6 months, which was how much time they had, but they did it. And so I'm really proud of them. And we got consensus, which is more. I wasn't planning on consensus, but I'm glad we got it. So ACOs is another opportunity that's being discussed. But first and foremost, employers want to lead with quality. Nobody wants to send their, I don't know if you guys know what leapfrog is, but, nobody wants to send their kids, their parents, themselves to an F hospital or a D hospital. You want to go to an A hospital, right? But you want it to be fair and reasonable. And so we have to do both. We have to look at price and we have to have the right quality set. And then we just need to develop a payment model that marries them. So thank you so much for your time.
Thank you very much. One or two questions for Gloria or Marilyn, and while I pull up the other slides, and then I'd like to just share one or two things that we might do here in Colorado, and then like to get into our panel discussion. So a question or two for Marilyn?
You're saying for the panel.
It's a shy group.
I just want to say one thing that I forgot, that I thought the governor's people might appreciate. One thing that, this was interesting. One thing that, that 2015 legislature did was also mandate that we lower the OPEB liability. Do people know what OPEB is? It's an account. You know how big of an issue that is with public entities. The state of Montana got hammered by the rating agencies in New York for the bond rating. The OPEB liability is $347 million, and that's the projected liability to offer benefits to the employees during their that are working now. You've got to recognize that now, and it's up here. So one of the things they said is you better figure out a way to fund that. And I thought, why fund it? Why don't you just lower it? And so through all of this process, being the accountant and loving pension benefit and post-employee benefit calculations, I really focused on that. So we did make some changes with retiree benefit. No longer could a retiree leave the plan and then come back on, then leave, then come back on. It was once you're gone, you're gone. And we also went to AGWIP and some other things. But the biggest change was that we went to reference-based pricing. And the actuary finished the 2017 report. Now, this is 2 years later. He finished the 2017 report. It was just audited. And the report came out Friday. So it's no longer 347 million. Our OPEB liability is 52 million. Wow. Yeah, just clean it up. No, London.
Well, there you go. All right, so a couple of conclusions, and then I'd like to ask our other speakers and panelists to come up. Here's what I would suggest. Meaningfully addressing pricing will require direct employer involvement, and I think the health plans in the room are interested in having employers join them in that conversation. The current methodologies are just significantly flawed, and we don't need to go into it, but whether it's percentage of cost or discounted charges, case rates are directionally correct, but again, need to be expanded and blown out into episodes of care. And then they need to be referenced to Medicare, because again, it's just a matter of unit use times unit price. And the third thing I would argue is that alternative methods for using these payment levels. So you know, if for instance, the Geisinger system out east, they have their own health plan and they cut their payments. They started with just a 10% reduction on all their open hearts, and the hospital actually made 17% more money. 17%, and this goes to Kim's point. I don't care what the profit margin is. It's fine. I want to pay a reasonable price. Right now, the 8 to 40% profit margins that Baumgarten reports for the state of Colorado, that's driven by price. That is not being driven by efficiencies or effectiveness. So that's what we have to move away from. By the way, in the news, I don't know if you saw this, but 15 out of our 48 hospitals have been dinged by CMS. We're the 8th highest in the country. And this was, again, you have these references. There is a solution to addressing this pricing, and let's relate it. Let's use reference pricing and relate things to Medicare. So we went through those. We talked about that. My last comment would be this. In healthcare, and I was a marketing major looking at how you purchase goods and services. And in healthcare, it's really a two-part purchase. The employer is the wholesale purchaser. and you buy services in a way that arrange an array of services that your employees can access, and then they actually buy at the point of service. You need to be intelligent at both the wholesale purchasing and the retail purchasing levels, and have that as part of a multi-year plan. What I'd like to do, and these are the three components. What I'd like to propose today, and we'll get to this after the panel, is at our July meeting, and I think it's July 12th, the second Thursday of July. We plan to convene. I think we're planning to have a discussion around mental health. Barbara Martin and a number of other folks from SEM and mental health will present on integrating mental health because that's such a big issue. But I'd like to convene the purchaser members of the Colorado Business Group that morning, if I can get folks to come an hour or two early, as well as any other employer purchasers that are interested in attending. And we'll have a discussion around what you heard today and what could be the next steps. And so I'm soliciting all of your involvement, as well as if you would please bring your CFO, because this is certainly it's a critical personnel issue, but it is also a financial and fiscal issue. So that's what I'd like to do. All right, without further ado then, what I'd like to do is ask Kim and Representative Janal to come up to the table. We've got our speakers as well as Janet Pogar. I think everybody knows Janet. I think you know probably Janet, most of the people in the room, and just really esteemed lady who's been involved in the hospital contracting space for years, and I just really value what you do and your experience. Representative Janal, as was mentioned earlier, is the chair of the State of Colorado House of Representatives Health Insurance Committee. Okay, and I thought it'd be really important if you would participate in this discussion. So thanks very much for being there. I'd like to ask each of you in just a minute or so. I'll go right down the table. Or Kim, maybe I'll start with you. What role do you think Medicare Plus pricing could play in creating a more value-based market? And here, you can pass that down.
I think, as Gloria said, it's a great baseline for transparency. It's a good starting point. Medicare has huge amounts of data. Part of Colorado Hospital Association's transparency was pulling Medicare data. I think just starting at that is a great point of reference for us to all understand the hospitals, each hospital in our community. I think it's a great place to start the conversation to learn from Marilyn, and thank you. I think I fell in love. Yeah. I fell in love with Marilyn. So to figure out the reference-based pricing, and the state's contract has gone out to bid, so I'm going to call Jim Taylor and talk about our conversation and figure out whether you two can connect. And how can we learn from and start, and how can we, in the entirety of the payment system, starting with employers, could be a great source for that. I think on Anna, I would love for that to be available to all of us on each hospital to clearly understand that, and to get this RAND study at the same time. So I think it becomes a platform for all of us to have more transparency and to figure out what the next generation of pricing and value-based looks at. So it doesn't matter if we do value-based pricing. I'll use pharmacy, for example, just to serve the point. If you have a $500,000 drug and you do value-based pricing and get to $400,000 when it doesn't work, it's not terribly helpful.
Right.
But if you set some value-based pricing and a better reference point, I think it can serve as a whole lot. So I really appreciate your leadership in bringing that. I learned a lot today. So
oh, great. Thank you very much. And by the way, we did set up, you've either spoken with or will speak with Marky Davis, right, Marilyn?
Yes,
Yeah, she was. I'm not sure she's still here, but we are having this discussion with that group. Representative Janal.
Yes, thank you for having me here on the panel today. I am so impressed by all of the speakers that have come before me, and I actually am not speaking, thank goodness, because I don't think I could do as good a job as any of you. And I've learned a lot. I've also had my eyes opened a lot by the information that has been presented, both from Montana and Indiana. And you know, when this question was posed to me, and listening to the speakers today, I have to say that, you know, when you look at charge master, that's really arbitrary data. And it's data that's just pulled from who knows where. And it's not data like I know data, and I, like Marilyn, have not been in politics prior to being a state representative. I'm a scientist, I work in big pharma, and I'm looking at price transparency in big pharma right now because I'm very concerned. But, you know, I think what we're looking at as far as this data, this is scientific data because this is Medicare federal data. It's based on scientific evidence and facts that come from the feds. And so that's why I think that looking at going from Medicare and going up is much better to negotiate or to look at from what I've seen from all of our speakers than going from top down. And so, you know, I've been working on transparency issues for 6 years now in the state legislature, and my number one is the second on your list, and that's pharmaceutical pricing transparency. But we've also done a number of bills on hospitals and transparency with hospitals, but we haven't gotten very far. So that's, I'm very much in favor of this.
Maybe Janet, if we haven't heard from you yet, maybe you could weigh in.
Normally I'm shy, but today I'm not.
Yeah.
So I'm Janet Bogart. Thank you very much. This has been excellent. And I have been doing hospital contracting, et cetera, for almost 30 years. So yes, I'm old. But I feel like it's Groundhog Day representing an anthem every year. And I was telling my colleague Erica, who's here with me, like, it's Groundhog Day. It's the only way I could describe how I feel like every year at the contract negotiation table. So hearing the discussion about top down, bottom up, and the world that I work in for the big health plan and for the other major carriers in the room, you'll understand this, is that so there's a report out there called the Hewitt Report that large employer groups get access to data. I'm not going to, it's what the industry has used for years, but the comparative is who has the deepest discounts? Which BUCA plan, Blues, United, Cigna, who has the deepest discounts gets the business. At least that's what I hear from my leadership saying, well, geez, Janet, what's happening in Colorado? XYZ employer group won't even let us have the account because someone else has deeper discounts. And so who gives it about the discount? I mean, I'm like at the end of my career with hearing things, Hewitt discounts matter, payments matter, but looking at discounts and I'm getting an 80% off, for example, one large system in Denver, look at their charges to what we're paying, probably 80% discount off their charges, and we're paying them free or 100% of Medicare. So there's relativity on how important those charges are in a report in terms of how we're evaluated. So looking at it this is critical. We're at a critical juncture where we've created, and I'm not playing the field, we've created part of the problem is a deeper discount. I got to get a deeper discount. One of the slides that really stands out to me that is pretty profound when you look at the hospital variability to the physician variability. We have negotiated, and the physicians represented in the room know what I'm talking about. We have paid docs for years, for the most part, on a percentage of Medicare. That's where you see that less variability. It's been a percentage of a fee schedule. And so that is proof point to me where, geez, you get what you ask for. And when we have paid negotiated hospital contracts, top down, not bottom up, that's what you get. So I think you know my opinion, Bob. And Bob and I have breakfast as often as we can. And he gets very passionate at times, not by me.
No, about business. Now I get be clear. It's strictly. I get strict. It's about. Let's not start any rumors whatsoever. All right, thank you very much. On that note, I think maybe we ought to throw it open to questions for our panel and for our speakers. Yes, ma'am.
Any idea how not athletic I am? My question was for Marilyn. So I don't know. I figure it doesn't hurt to ask. As you were kind of bringing in all of the out of control prices that were going on, have you seen any sort of correlation, positive or negative, with your employee health outcomes in that process?
That's a really good question. We actually are monitoring cohort outcomes through our health centers. And it's really interesting because that's where we're focused more on the care, and that we're seeing real improvements. Improvements for Montanans in every single cohort except BMI. We know how to eat. But that's America. So we are seeing outcomes through that. We do have with the TPA a strong disease management group that is focused with that. We have identified the high care. We now have a program through the on-site clinics of the cup that a person can wear at home, and it sends you Bluetooth, and the providers with the health center are monitoring that. Like, we're trying to hit the disease states. One thing that's not really answering your question, because we have not, in relationship to reference-based pricing, we're assuming pretty much we haven't seen the care change. And we had a reporter out here this week from ProPublica in New York and NPR in New York wanting to cover what we've done. And I guess I never thought it was that big. I was just told to do it and did it. But they were talking about what was the noise for the members through all of this with reference-based pricing. Well, after everybody has signed on, I think you could ask the state of Montana employee about it, and they don't know that. Nothing changed for them. Absolutely nothing changed. Maybe the hospital stay got short, but they're not complaining about that.
We are trying to look at that. I think it's important for all of us to look at that, whether you've implemented or are implementing or considering implementing. And so we have a really robust health information exchange. They have the lab data, clinical data. You cannot get patient outcomes data just from claims. I'm a provider. I can tell you that you cannot. It's limited. Okay, you get some. Okay, they're not getting readmitted to the hospital. The ED visits are going down. Utilization's going down. Is utilization going down actually an improvement in healthcare? No, you don't know that. It could be dead. So, so I'm just saying that doesn't mean that they're improving in healthcare. For diabetes, there's A1C. For cholesterol, there's LDLs. For obesity, there's BMI. For blood pressure, hypertension, there's blood pressure. So we are working with our health information exchange now to develop employer level. It's population health management. All the providers do population health management. How many employees, covered lives do you have? Say this is poorly controlled, suboptimally controlled, controlled. Put all your people in the buckets for A1C, LDL, and all these measures. And then every quarter, the numbers need to be going this way. Okay, all the numbers, the poorly controlled need to be suboptimally controlled. The suboptimally controlled need to get to controlled. If you have disease management vendors that all on-site with all your solutions, if your population's getting worse, fire those people, and start over.
Succinctly said. So the next question, and when you ask the question, if you would please identify yourself first.
Hi, Helen Drexler with Delta Dental in Colorado. I'm here as more of an interested citizen of Colorado, not necessarily as an employer, but that too. It's really about the cost shift or the unintended shift that happened after you put your programs in place, particularly in Montana. Did you see other employers wanting to move there as well because of your experience? And did you see the hospital's cost shift to other employers because of what they were giving you now in terms of cost pricing?
That's a really good question. There are other employers that wanted to come on and do it now. They didn't before. But there are two large association groups that have contracted with that too. I would argue, no, we have not seen cost shifting private. Remember, I worked at Blue Cross Blue Shield and I worked at EDMS. in the financial area. And I'll tell you right now, those large private employers have screaming deals with those hospitals. They're maybe a 2-hospital town and they're getting 125% of Medicare right now. And I would argue the public sector has always been on the other end. I would say, you know, and that sounds a little vindictive of me to say, well, buddies, now it's time for you to eat it too. We did not see cost shifting, and we have worked with our TPA, we've worked with other entities. You know what we did see? We saw, which I had one of the large carriers in Montana tell me, they saw the hospitals not increasing their charge masters, which I didn't expect would happen. They said they just weren't really. Single hospital. All we did was get rid of the fluff. No hospital had to change how they operate yet. We're not low enough yet. No facility changed how they operated. I think we just got rid of the fluff and they're going on fine. So our next move is moving in, and then what kind of incentives can we give, like you talked about?
Well, and that's a great, and if you haven't read, and I think the references in the handouts, Jamie Robinson's paper on the choice architecture of reference-based pricing. It's a marvelous paper. Great question, and I just wish I could get you to give direct answers. I just, I don't know. I appreciate it. Other questions? Let me, we've got time for a couple more questions. Yes, sir.
Sure. Hi, David Keller. I have to ask the question, all of the quality measures and stuff you've been talking about generally are around adults, all those data points you were talking about that come out of the HIEs are generally adult-based, and Medicare is generally adult-based as a reference point. So if we move to reference-based pricing based on Medicare, what about the children?
I think that's directed at me, I'm not sure. So that's an excellent question, and at our quality meeting that did come up. We had a pediatrician, actually 2 pediatricians that were on our panel, our task force, I should say, and you're right. There aren't good measures for pediatrics, period. So that's what we learned, right? So it's not just in Medicare, but just period. And so you guys somewhat become exempt from this process. Now, our pediatric hospitals are part of 2 large health systems, so they will get. We will not have specific pediatric measures. Looking at the CMS measures that we did look at, we had 187 CMS measures. I mean, these poor hospitals and these providers, they are just measured out, right? I mean, we do not need to make any more measures for them. They measure, and measure. What we had to do was we lined up CMS, Leapfrog, Anthems, United, and Joint Commissions together. It started with a crosswalk. We cut out all process measures. We only looked at measures that had been tested in the commercial population. That's how we got around that. That means in the 18 to 64 population, not just the 65 up, which there's a whole slew of them that are just tested and measured. And we try to be evidence-based. And since we couldn't find any evidence for pediatric measures, we don't have any. We have immunizations is the closest that we have.
And the first rule of quality improvement is steal shamelessly. So we're going to take our 21 measures and share that. Yeah, no, that's what we're going to do. And what I'd like to see happen is for the commercial market to work with HICPOF and the health plans to see if we can come together around seventh alignment, right? So that the people aren't being pulled.
On this hospital transformation priority list, quality measures we're in consensus. First down the road is physicians, second is hospitals. So
That's great.
In alignment, that means all of the carriers agree with all trying that multi-payer collaborative, which includes HIPAA, is coming up with those standardized quality measures to make it easier on the provider community because we are measuring that
we can come up with a better way to do it. And thank you, providers, for encouraging us to do that.
Kim sort of called me out because she sent me that document and I've not read it yet. So I would have known that if I had read what you sent me. Other questions? Yes, sir.
My name is Andrew and CEO of 9 Health, a small nonprofit here in town that works with prevention. My guess that my question is around prevention. I'm curious from both of you, I mean, we're talking strictly about hospitals here, but the cost that lands in a hospital is driven directly by preventive measures or not. I'm curious if this drove any additional discussion around how prevention factors in the state of healthcare population. This data has really impacted that.
That's a very good question. I think on the prevention side, we've been working more through our health centers. We require people to have, they get a discount off the premium if they go to the health center to have their health risk assessment, which is the blood draw, the depression screening tests, all of that. They have to do follow-up appointments, and that's zero cost to them. So we offer the health center, and it's primary care predominantly, and it's been that gatekeeper. We are with a lot, there's a care coordinator there that's calling people and following in to take care. And then the MTM project we're bringing on is to help members prevent some more catastrophic issues by making sure their meds and things are right. The only quality metrics I have are really from our health centers to see, and we watch them closely to see how they're moving the dial. But it's definitely, I agree with you, prevention is the key.
I'd just like to add in onto that. I ran a bill that was very similar to the Oregon bill for primary care, making it more affordable and to kind of change the primary care physician infrastructure on how we pay primary care physicians. Right now, they get 5 to 8% of our health care dollars, and they really need more because they are, and the way they get paid, we're looking at changing that to not acting upon an illness, but on wellness and prevention, just like you mentioned. And that went through the House Health Committee. It was House Bill 1365 this year, making healthcare for value and investing in primary care infrastructure. However, it did die in another committee. So we'll review that and see if we can bring it back again.
So I just want to comment, you have to measure quality. I'm rooted in evidence, right? Just measure it. It's develop a template and measure it. So there might be other health plans here that are doing value-based payment models. We've been working with Anthem very closely to do this. And so the new cooperative care model is a primary care model. And it makes physicians take downside risks if they're going to participate. So they have to hit some measures, right? And their patient outcome measures. And that's really important. They aim to have clinical measures in there as well. But it's difficult to get those clinical measures across all states. So I would say, as Colorado is really interested in that space, figure out how to get clinical measures over to your health plans so that they can really make sure from a population health perspective, your population's improving. The issue I have with health risk assessments, and all of our employers do, and they're all free. The problem is, well, then what? You did a blood pressure, you did an A1C, you did a BMI, you did all this stuff, and then you do it again next year, and then nobody's looking at it. There's no interventions. You don't sit there and go, oh my gosh, 85% of my population's obese. I'm going to develop here all these vendors. I'm putting out an RFP, and then I'm going to measure those vendors to make sure they're actually improving care on a quarterly basis. Because if you pay them PMPM, which everybody pays everybody PMPM, which is a totally flawed model, because if you're going to pay me per member per month to do anything, I'm going to get, if you pay me $100 per member per month or $5 per member per month, and you're going to pay me no matter what, and I don't have to achieve any outcomes, I'm going to be as lean as possible. I'm not hiring a dietitian, a PharmD, social worker, anybody, because that costs me a lot of money as the vendor providing the service. I'm going to make it phone call based, or I'm going to fax something to the doctor.
I would just add one comment to you about the prevention and the preventative services. members have access without, or for colonoscopies, for example, they pay nothing for for just their preventative colonoscopy. And what we have seen is interesting now that members are paying for them, the cost for our preventative colonoscopies has gone through the roof. Just so, and prevention's good, and it's just now all of a sudden there are no freestanding GI labs, and they're all being done at what used to be freestanding and now they're hospital owned. So there are some, I love prevention, but when you put no cost behind it, there are some other unintended consequences that happen somewhere down the food chain.
Yeah, great. All right, I did want to mention, by the way, and I'll come down to you, Claire. I did want to mention, if you have a question, if you want to know what your organization is paying as a percent of Medicare, Civic can run that data for you. And I think Pete was a contact, is that right, Jonathan?
Yeah, that's a good place to start.
Yeah, Pete Sheehan, and I think you have his email and the handouts as one of the key takeaways. So Claire, introduce yourself.
Hi, Claire Brockbank with Segway Consulting. Now, this is for Janet, I think specifically, and that's what we've talked about when we talk about large state employers or large business groups is the self-insured market. As a health plan, and you've negotiated every which way, right? What do you see as a health plan in terms of your role in using a negotiating from up from Medicare in order to create a different basis of payment for your insured groups so that this value translates down to small businesses and the businesses on the exchange and et cetera. Does that make sense?
Yep, sure. That's an excellent question. And typically what we negotiate, Claire, is because we're affiliated with the Blues, we have a hard time, because of our association rules, differentiating between what a local fully insured member would have to pay versus an ASO client. So we do not differentiate how we negotiate, but I will tell you, if I sat down with a hospital and we've been in some contentious negotiations recently, and we have some throughout the rest of this year, if I said, I want to pay you 150% of Medicare, I would be kicked out of the room. I mean, if I could walk away, and we have the support of employer groups that said, yeah, walk away, we don't need them. We just having one hospital system potentially going out of network. I mean, I gotta get weekly updates, I gotta do this, it's being monitored up here. It's like, so I think that's great. We need a lot of support and a lot of business community support to say, this is really what we think needs to happen. And it will automatically happen when you say the local individuals, we have them on a narrow network where we're already getting some additional discount off of this high in the sky, although it's fixed price, but it's still very high. But that's an excellent point. We shouldn't treat them any different. It shouldn't just be the large employer groups that get the benefit of this. I 100% agree.
Yeah, in fact, in one of those passionate meetings that I had with Janet, we talked about this, and really with regard to and what some other folks are doing, like Northeast Business Group on Health, where Carolyn actually used to work, they do have user groups, right? And the health plan and the employers get together and they talk about, and then they will engage the hospitals in pricing discussions, because I don't really know that the employer wants to have that discussion without their health plan at the table. But on the other hand, if our administrator brought me as the president of the school board to the table, I can have a good discussion with those folks about our community and its needs. And she probably can't have that discussion, frankly.
If I could just add, moving from the commercial private side, Wall Street, to the public side, your engagement in the legislative process can be underscored enough. So we have a legislator like Representative Janal and Representative Kennedy was in here today, and these are folks that are trying to do the right thing. And when we don't pay attention, I'll put we back out in your seat. We don't pay attention until it touches us specifically in our industry, energy, etc., that's when we all fall down. So my ask is that you recognize that that we do a better job of communicating with the employer groups, but then the employer groups need to do a better job of standing up in unison and say, this is important to me. And when the Representative Janela's peers only hear from those who are against it because it represents their industry, we all lose. So my ask, and I've learned hard way coming into the state, is incredibly eye-opening. If there was a way that I could just help you understand how important what I just said is, we must stand up and support the legislators who are supporting us and be more knowledgeable of it. I appreciate your leadership around that. Thank you.
Yeah, in fact, let me add to that, and Vicki, I'll get to you in a second. Let me add to that. About several hundred years ago, in the early 1500s, a guy by the name of Niccolo Machiavelli wrote a little book called The Prince. And what he said is, there is nothing in the world harder to change than the order of things. Because the person seeking the change will only have the ardent and unrelenting opposition of those who will lose, and he will have the lukewarm support of those who will gain. And the reason he said that's lukewarm is because you can't envision it. And that's why we asked these folks to be here today, because they gave you a vision of what could happen. Okay? And I'll get to that in a minute. Vicki, if you introduce yourself.
Hi, I'm Vicki Mayer from St. Vrain Valley Schools. I was actually going to ask if just what Kim mentioned, hearing from employer groups, and I think CBGH is well respected and has huge representation of lots of different types of employers. Is this something that we're going to be talking about in our July meeting, about whether we might be able to use CBGH to be our voice and to help us to get that representation? So.
Yep, very much so. And in fact, one or two of our larger members have suggested that they'd like to see how they could lead that discussion. So we will have that discussion. Yes, ma'am.
Catherine Lloyd, the Hospital Association. First of all, thanks for convening us. It's been a really fascinating day, and I appreciate being here, although I don't love everything that's been said about hospital building.
But thank you for being here.
No, and we're always happy to be at the table, as some folks up front can attest. The question I have, and it's really more of a comment, I'm going to try to put a question mark at the end, is one of the challenges we've always faced in Colorado is how fragmented our payer and provider and employer markets are, right? So we don't have a super dominant payer, like I think you mentioned, in both Montana and Indiana. We've got a payer who's 60 to 80%. We don't have a dominant hospital system provider. We've got 6 or 7, depending on how you count them statewide. And among employers, we don't have kind of a mega employer either. And so getting all of those forces to kind of march in lockstep without a dominant player, whether it's a health system or a payer or the employer community, is really hard. And I think we've struggled with that. And I appreciate Kim's last comment, but what my job is at the Hospital Association is making sure that we do work collaboratively as a market so that we aren't reliant on the legislature to force us to do stuff. Because I don't know that, especially in Colorado, that's always a politically feasible option. So, we struggle with that as hospitals, health systems, but also as a healthcare community. And I would just kind of love your thoughts on kind of how we go about creating that uniformity of progress.
Good question. Kim, I'll get to you in a minute. Gloria, you've done a lot of this. You've brought these folks together. You've met personally with all the hospital CEOs. What's your experience?
So we work very closely with all of our hospitals. We have 4 large health systems, several small, medium-sized health systems, and then a bunch of critical access hospitals and independents. Less and less of those as years go on. And so I would say, we have to work together. And we really do to create the mass change that we want to impact all I'd say all Hoosiers, all Coloradians. I don't know what you guys call yourselves, but citizens of Colorado. What do you call it? Coloradans, sorry. Okay, so
to impact all Coloradans, you know, not one employer, not one hospital, not the one-offs. You have to work together. And I think, honestly, Bob's group is the best group to do that. It is going to take everyone to roll up their sleeves, be at the table, have task groups, figure out what you want on quality, figure out what you want to do on price, figure out what you want to do on policy. And so policy is important because, you know, a little bill can create mass change just like that and save you years of time. So I think it is important to engage your legislators, and it's actually critical because they can open up great opportunities or limit them. And so if you're not engaged in that space and you're trying to be innovative, there may be, you know, barriers or opportunities there. So work together through Bob's group would be my recommendation.
Well, and so Kim and Representative Janal both want to weigh in on this, so.
So a couple of things. One, I think for the first time in my position's role here as the Executive Director of Healthcare Policy and Financing, there's an actual goal that we've created in cooperation with the Governor's Office that says we will touch 1,000 stakeholders, understand the 3 to 5 year plan, to get input on 3 to 5 year plan. So that is, our department is a conduit for the collaborative energy and ideas, as Catherine has indicated. So I'd ask you to work in partnership. Through that collaboration, we are calling on all of the big employer groups, and this group should be a force that is not reckoned with. It should be an enormous force. The chamber as well, color of concern as well, that we have the ability to pull all those amazing ideas and power together to get our transformation as we want it. And the second thing I'd say is I've asked for industry cooperation. So when we met with the Health Hospital Association, it could have just been Medicaid using provider fee meeting with the Hospital Association. Instead of that being government talking to industry, what we did is pull together all of the payers. If you had more than 3%, you were in the room. And as we are negotiating this reuse and redistribution of the hospital provider fee, it's the industry, 80% of the payments. The only thing that's on the table is Medicare. That's the first time that's ever been done. So we're trying to do far more than we ever have. Industry talking with industry to be collaborative, and then if we complement that with legislation where we need it, I don't think it can stop. I think we can get what we need, not get what's negotiated for from the wrong side of the table. So thank you for the question and our commitment to continue to lead into that.
And I want to thank the first comment about how everybody's involved here. And I hope that I get invited to the next meeting because and other legislators that are concerned about healthcare. And I know they will show up unless they're out of town and have other plans. But when legislators, at least the ones that I know, and I know what I do when I have a bill, and I think Catherine can attest to this, is that I call a stakeholder meeting of everyone who has any type of interest, whether it's 1%, 0.1%, or 99% interest in the bill that's coming forward or that I'm bringing forward. I want to hear the positives and the negatives, and if there are issues, let's work them out, because Catherine has come to many of my stakeholder meetings, and there were issues. And we sat there, and she may not have gotten everything that she wanted, and we either, in regards to the legislation, but we worked it out. And that doesn't happen all the time. That's, you know, a lot of the time it does help, and it does work. But having legislators and stakeholder meetings with everybody that has a percentage, no matter what that percentage is involved, is so important.
Sure, Marilyn?
I wish we had a group like this in Montana. I really do. You're going to go further ahead than we ever dreamed of and in the right directions. Unfortunately, nobody really wanted to join my little club. Yeah, thank you. And I think when I tried to pull the school groups in, and I just spoke with them a week ago, They all have their own plan, their own broker, and they're doing the greatest thing in the world. They don't even want to talk to us. Meanwhile, teachers are not getting raises. Budgets are being cut. So I liked one of these slides. So I'm going to equate the savings on reference-based pricing to a teacher's salary. That might help. But I really admire what you've done here. I had no idea this could exist as a group coming together with the hospitals, with the brokers, with the payers to all come to the table. Colorado's so far ahead of Montana on that. I think we're still in a situation where the lobbyist that gets to the governor, gets to the legislator is the one that wins. And so I've learned a lot here. I'm really impressed with this group.
Oh, well, thank you very much. And I want to acknowledge Donna is here. This was really, Donna put this together 20-some years ago. And I'm just humbly trying to carry it forward. I think we want to respect your time and stop at the top of the hour, but we'll stick around. So I want to close on this note. Again, I pointed out that the theme of today's meeting was let's fix problems, not blame. If we want to change the way that healthcare is priced and delivered, then the only way we can do that is if we change the way we purchase healthcare, right? So really the responsibility is on us to change our behaviors, and if you like what you have, just keep doing what we've done with RFPs for the last 25 years, and you can have more of it. Or we can get together and think about alternative ways. By the way, a couple of legislators had intended to come today. Representative Kennedy, I don't know if he showed up. Oh, where at? Oh, okay. So I appreciate that. And Representative Foote couldn't make it. Both of whom have sponsored transparency legislation. But I think this really represents kind of the right approach that we've talked about today. I so appreciate Marilyn and Gloria coming in. Thank you very, very much. And Janet and Representative Janal and Kim, thanks so much for taking your time and really, really appreciate it and all the work you're trying to do to align the marketplace. So thank you very much. Thank you all for being here today. Great discussion.